Hello. Hi, Ben.
Hi, Professor Nee.
Hi.
Hi, nice to see you.
Good to see you.
Yeah.
Thanks for joining early, and hopefully in another 15 minutes we'll start the session. And I can see Vlad is on the line as well.
So every speaker have 15 minutes?
Yeah, I think it generally is about 20 minutes and then 5 minutes discussion. But when Imad joins, we will just confirm it, and we'll confirm it. Generally, it's about 15 to 20 minutes.
Mm-hmm.
How are things in China?
It's now it's just opened, and now the COVID-19 was not so terrifying.
Okay.
Yeah.
I think before the pandemic started, I was planning to come to your place, but I think very unexpectedly the whole world changed, and I had to cancel the plan.
How many years ago?
That was just before. I think in 2019, I believe. We've been in correspondence. We emailed and you asked me to come over. But things changed afterwards. But I hope things will come back to normal soon.
Yeah.
So I was just looking at the instruction. Each presenter will have 20 minutes, and the guest of honor will be assigned 30 minutes. So it's 20 minutes for everyone, I think. Hi, Imad. Hi, Imad. You're muted.
Good to see you.
Good to see you.
Good to see you. Hi.
Ramesh.
Hi, Vlad.
Hi.
Welcome back to home.
From Cairo.
Was a long trip, yeah?
How was it? Good trip?
The Congress was well. The organizers, the PCO they were having, they were really difficult people. But otherwise, it was well attended. Imad, we missed you.
Sorry, yeah.
You should have been there, but understand that you were not able. But it was real good meeting.
I'm sure the city is a busy city, but it has historical background which make it compensate.
Oh yes, we visited both pyramids like Saqqara and the big ones. And then we went to the new museum where all those kings are located, and it's really nice. It's really nice. you know, all those Seti and Ramesses and these. That was exciting.
Yeah. How is Shanghai doing, Benzo?
Hi, Professor Kanan. It's okay. I think now we are just open, and COVID is now it's reaching to the peak, I think.
Oh, I see.
But it's not so terrifying. Yeah.
Amazing, the number increased in New York, because when I left New York, my two daughters got COVID and their friend, and I got it on the way back, and but it was a mild one, luckily.
Yeah.
Right.
You know, a combination of COVID and regular flu.
Yeah.
That's really difficult. I now have it, you know, I'm like...
yeah, you look like you have some sort
Look,
of...
you have it.
Yeah,
some of it.
that I am, you know. That
So you just have the regular flu.
Yeah.
Professor Bennett.
Yeah, it's that we caught on the way back from Cairo.
Yeah.
Probably on the plane or somewhere. You know, it was an exciting journey from Cairo, because we started with the plane, and when it was like to lift off, suddenly they braked and we went back to the terminal. And they gave us several messages what happened, and they were contradictory. And then we lifted and flew normally to Wien, but in Wien we have had like 500-meter run, and that probably was the cause, because we were very short of time there.
Yeah,
it was difficult trip, but Cairo is rather nice.
Yeah.
Weather-wise was good.
Oh, weather was excellent.
Yeah.
It was warm T-shirt all the time. You didn't need any jacket even in the evening.
Okay. Professor Takio.
Hello, Professor Kato and
Professor
Professor
Kato.
Goto.
Hello.
Wonderful to have you all.
Yoko.
Hello.
Hi, how are you?
Hi.
Thank you for invitation. Thank you.
good to see you. Good to see you, Professor.
Good to see you.
Hi, how are you? How is England?
Yeah, England is, it was in severe winter about last week, but now it's getting better. More sunshine now.
So in Japan it's very cold now.
Is it?
Very heavy snow. Yes.
Yeah.
The same.
Very
Yeah.
heavy snow. Okay.
Shanghai is also
No. It's quite warm.
quite
It's
warm.
yeah.
Lucky you.
ロト先生こんばんは。
Well, we are glad this time we have a good Japanese representative on this webinar today.
You do? That's great.
Wonderful.
Hi Vladimir, how are you?
Vladimir.
Yeah,
Vladimir, how are you?
I'm doing well, except for the flu. You know, I caught flu, and it's really heavy one.
Oh, okay. Please take
Headache
care.
and bad breathing, you name it.
Oh,
And Eva also, so we just have it at home, you know. It's not fun, not much.
so but your voice is not the real.
No. I don't feel well, I can tell you.
So sorry for you.
Yeah.
So I think today we have 9 lectures. We tried to limit the numbers. We thought this is a final webinar for this year. We should celebrate that you all leave early to your families, hopefully. And I know the time difference makes it difficult for people in Shanghai or in Japan, because I think it's almost coming to 9 o'clock in the evening in Japan. What about in China? What is the time? 8. So
8 p.m. Yeah.
We
So
are privileged, and of course for Matthias. Hi, Matthias. In Argentina.
Hi, Matthias.
Early morning now. I think, is it 7 or not yet?
Yes, it's 9 a.m.
9 a.m. Okay.
Hello, everybody.
That's okay.
Hi, how are you?
Hello.
Matt.
I'm fine.
So you are
Thanks.
ahead of New York. And here we have Basant as well from Mumbai. Hi, Basant. Seems you are ready
Hi.
to jump and dive into an aneurysm clipping. Unmute yourself.
You're muted, Vasanji.
No, my topic is dilemmas of neurosurgeon, dilemmas of a neurosurgeon. That's my topic.
No, I'm talking because I saw you on the scarp. And
Oh,
I
yeah.
you're ready
Okay.
to jump into surgery.
No, I'm here. I'm not going to go away. I want to be here.
Yeah.
Hi, Yoko. I see.
Hi,
Yoko.
how are you? How are you, Mishra?
I see.
So now we have a two Indian fellow now.
Oh, you did?
One,
Oh.
yes. You know the Dr. Sachin and Dr. Kapil.
Dr.
From
Who?
Mumbai.
Sachin, I think, I
Sachin
don't know them
Kapil.
personally, but I know they,
Yes, another one is Kapil. Maybe Dr. Kapil, maybe that he is very young.
yeah,
So
they're younger people, so I would not know them properly. But
okay.
Hi, Professor.
Vladimir, I see Vladimir is trying to fix some computer or something. What are you fixing, Vladimir?
Yeah, I'm afraid that I again will be unable to put presentation mode. You know, I have problems
you
with
hear
that
us?
all the time.
Yeah.
Hi, good afternoon.
Hi.
Good
Good to
evening.
see you.
to you.
Good afternoon.
Good
Present
evening to have you
konbanwa.
with us
Good
as well.
evening, everyone. Konbanwa.
Ma.
Thank you very much.
Wonderful to have you here. The background is a lot of light. It looks like we are going to the Mondial again on the soccer game.
Yes. Do you know? Firefly. Have you ever seen fireflies?
Oh, yeah. I have
Yeah.
seen a lot of fireflies.
This place is famous for summer fireflies.
Oh, wonderful.
In my
Oh.
near my town. Yeah.
Nice.
Although this is not a firefly light, but
Yeah, it's too big for
Not the green
firefly.
one.
right.
Okay.
This morning, we are going to have two sessions. One will be dedicated for revascularization mainly, and there is one lecture on skull base. And the other one will be mostly Cavernous-like and vascular. And we have put, of course, we are honoring Professor Robert Spatzler for his lifetime achievement. He is a teacher of the teachers. I don't know when he will join, but we put his lecture to have a civilized time at the second session. So I think the first session will be chaired by Professor Vladimir Benish and Professor Giovanni Bocci and Francisco Damasa. Francisco sent the message he will be late. Anyhow, he is the last on this chairmanship. So I leave the venue for Vladimir to start if the time allows. Let me see what. Yeah, we are ready to start if you would like.
Okay. It's my pleasure to introduce Professor Yoko Kato, who really is agents movement behind almost everything what happens and what we all are enjoying and doing. Yoko, it's really a pleasure to have you here with us. And you are going to talk on aneurysm wall pathology. So
Yes.
in order to save time, I don't think that I really need to introduce you to the audience because we all know you very well for many years. So Yoko, please.
Okay, thank you very much. So I appreciate the both Imad Kanan and also the Vladimir Benes. So they are a great organizer of the wonderful association of the regular webinar. So this time I heard the Robert Spatzler is lifetime his achievement. I think of course the robot came to Japan many times. So when I was middle age, not young. So almost every year he came to Japan as a special guest. The annual meeting. So I really thank you very much for Robert Spatzler, his dedication to our, especially the vascular teaching. We learned a lot from him. So today I would like to talk about several aneurysm wall pathology. So I think everybody knows So there are very many types of the aneurysm. When I do the aneurysm surgery, we encounter so many the aneurysm wall, sometimes very hard, sometimes very thin. So I think it's very interesting for maybe the vascular neurosurgeon, I think. So the luminal aneurysmal vasculopathy, so we have so many factors. So one is turbulence, the shear stress, and the flow shear stress, and also jet effect. And another interesting thing is inflammation, infection, or collagen disease, and the dissection. Those makes intracranial aneurysm. So abdominal aneurysmal the vasculopathies. So one is a structural vessel, the wall disease, that is very important, and the dissections, and partially thrombosed type of the aneurysm, and also the outside of the vessel by the basal. So this is very the key words. When we getting aging and the offensive pathology mechanism, the one is hypertension or smoking, so on, and also the defensive system, the pathology mechanism. It makes the proper the spontaneous self repair of the vessel wall. So this is one of the mechanisms of the thrombosed aneurysm. So there are two. One is vasospasm, and this one is another type of the thrombosed aneurysm, how it can be created. And another very important thing is everybody knows, of course, MRI, vessel wall imaging. So this can be the prediction of the aneurysm rupture. So this is one illustrated case, enhancement of the aneurysm wall and active inflammatory process, and aneurysm vasculopathy, and aneurysm wall disease, and the progression of the aneurysm. So this enhanced part of the wall of the aneurysm, this is corresponding this part. This is some very thin type of the aneurysm wall. So this is another case. There are the two aneurysm. The patient came to us with thoracic hemorrhage, ACA peripheral, and also the ACOM. So everybody thought the ACOM is ruptured one, but this is wall enhancement is peripheral ACA. So then when he did the surgery, the ruptured one is peripheral ACA. So this is a wall enhancement image, the grade A, B, C, D. So how large or how much of the enhancement of the aneurysm wall. So this is the 3D magnetic resonance before and after gadolinium showing enhancement of the wall of the bacterial artery aneurysm. So vessel wall imaging is a vessel wall imaging suppresses the signal of the vessel lumen and the cerebrospinal fluid and can image detect with wall signals. Its mechanism is quite difficult. The diseased vessels accompanied with wall thickening and conspicuity of the wall structure could be increased in the voxel dimensions. And contrast agent could enhance the lesion, presumably due to inflammation and the neovascularization. So aneurysm wall enhancement is found more frequently in ruptured aneurysm. So this is another very technological images. So just the wall study of the aneurysm. So this is the 3D analysis of the aneurysm wall enhancement. It provides topographic data of the entire aneurysm wall using MRI and specific aneurysm wall contrast enhancement. So predict of the rupture, the risk, and create 3D heat maps and histograms, the wall enhancement on 7 Tesla MRI. So we can get those images. And this is the rupture. This is the MRI vessel walls here. Here we can see the vessel wall enhancement. So this is the rupture place. Is we can see the some tunica media is ruptured, and this is again, and we can see the vasovasorum here and the mirror or peroxidase expressing cell straining. So those places correspond to the vessel wall enhancement place. And this is a rupture point of the aneurysm, the histopathological the specimen. So this is a parent artery, but the not necessary the thinnest part of the lesions. So that's more relation with inflammation or macrophage gathering. So this is a very complicated one. Is so the association of the inflammation with the rupture of the intracranial aneurysm is suggested. And this is again histopathological the specimen. So this is it's focus on the vasovasorum. So the blue one is the API nucleus. The red one is smooth muscle cells. So this is the one is animal model, and the other one is the human case. So this is the association of the vasovasorum with the degenerative change in intracranial aneurysm lesions. So the special stain to tell us how the degenerative of the vessel wall. So that part can be a future rupture point. So this is the induction of the vasovasorum around the site of the rupture. So this is a rupture point. Here is the aneurysm and the smooth muscle cells, and the neo vessels. The vasovasorum, that means the vasovasorum, so provide the route for inflammatory cells to infiltrate into lesions. And so accumulation of the inflammatory cells, that means the macrophage or neutrophils gathering those the part, it makes the walls became the weaken. So relative oxygen spaces, the proteinases. So this is a kind of the mechanism of how the vessel wall can be the weakened. So this is a partial thrombosis aneurysm. So this is extensive perifocal edema. Why? So the balls testifying for the inflammatory the component. That's why it associated with the huge of the edema. And also this is the macrophage, and also there are two papers. One is the macrophage, and also the migration of the macrophage, and this is prostaglandin E2, EP2, or NF and the kappa B signaling the potential therapeutic. So target. This is the paper from the Professor Aoki. So this is a trans and endothelial migration of macrophage. Already I talked. So there are two very famous papers. And another one is atherosclerotic change of the wall of the aneurysm. So sometimes we encounter such type of the aneurysm. And also, what about the fusiform aneurysm? 4 different underlying the etiologies. So this is 4 types. So sometimes according to the cause, maybe we can think about how to treat those type of the fusiform aneurysm. So this is another very complicated, very difficult theory. So this is CFD, the wall shear stress, and also the OSI is very famous the factors of the CFD, and also this is a fluid structure interaction FSI. So these two is a very important the factors, and pathology of the cerebral aneurysm is abdominal effect. So inflammation, infection, the plug-in disease and dissective the aneurysm, and also the aneurysm vasculopathy. So just I want to emphasize is that the CFD predicts aneurysm wall inflammation, so some relation with inflammation or degeneration. So this is a low wall stresses, adhesion and the moleculars, the rolling speed and of the inflammatory cell. So this promote a macrophage-dated the chronic inflammation and the atherosclerotic change. So it will be some of the wall, metalloproteinase production. The MAT production is makes the wall to thinning and further the rupture. So on the other hand, is just as there are two types of the aneurysm wall. The one is the sacral type of the small or large type of the aneurysm. So this is just a focal dilatation of the aneurysm, the blood vessels. So this is one of the just ballooning of the vessel wall. So this is very soft and sometimes very thin. So the aneurysm is very soft, and even though this is large, it's quite easy to close the aneurysm neck with mulch, the clipping. So this is just one of the type of the aneurysm, even the large one or giant one. So this is another one is partially thrombosed aneurysm. The thrombosed aneurysm is this is a not equal non-thrombosed to the aneurysm. So this is aneurysm with intramural thrombus. So this is another case. So this is a very thick next to the aneurysm wall, and this is the peripheral site of the pica aneurysm. This is a partial thrombus large and with OA pike bypass through the transcondylar approach. So for this type of the aneurysm, we not attack of the aneurysm itself. We do the OA pica, then we trap the aneurysm. This is a very clever way to obliterate of the aneurysm. So there are two types of the aneurysm. This type of the aneurysm related with the vasospasm makes up the aneurysm wall thickening. So this is the aneurysm. And the imaging is the ring enhancement in outer and margin of the aneurysm, dense vascularization. And so the giant aneurysm is partially thrombosed. There are several the treatments. So what you choose. So pathology is not intraluminal disease, but intramural thrombus. This is a wall disease, not the luminal disease. So the main play role is vasospasm. So proliferative, the disease of the vessel wall. So that the inflammatory or perivascular growth, the factor. So the CFD already I mentioned a bit. So the medial and the smooth muscle hyperplasia because of the high wall stress. So there are several still the theory. So the CFD is how the aneurysm, the enlargement, or how the rupture, and so those things. The CFD in aneurysm rupture is a lower the wall stress and the higher OSI. This is the most reliable the theory so far. So the large change of the rupture and higher wall stress than the surrounding area. That place is the so-called play. So OSI is already I talked is direction of the change of the wall stress during the cardiac cycle. So this is if the OSI is high and low wall stress, that means easy to be that wall becomes thin. So this is our data. Is the high pressure with a low wall shear stress with diverging vector with curved or fountain like a streamline. Those factors can make the aneurysm wall very thin. This is our the data, and again, so this is this part is the decreased wall shear stress at high pressure area that predict the rupture point in the ruptured intracranial aneurysm. This part is a rupture point. So this is some mechanisms of how the aneurysm grows. There are the three the main point. The some both progression intraluminally and also the macrophage infarction, neovascularization, microbleeds, and the thrombs in wall and neural degeneration. There are three types. Anyway, it becomes the aneurysm grows. And this is our theory. So one is this is a hit the wall, the high wall pressure, and the development of the recirculation flow. And after some time, development of the multiple area of the high OSI and the local recirculation flow. And finally, this is a remodeling. That means is the wall became thick from the thin to thick. So the aneurysm wall enhancement and that means is vasovasorum increasing. So this is a kind of my very interesting field, the aneurysm wall itself. Thank you very much.
Yoko, thank you very much. It was
Thank
a great
you.
lecture. Thank you. We have time for some questions. Someone would like to comment? Yes, Igor?
Good afternoon, everybody. Very glad to see you.
Hi, Igor.
Thank you, Professor Kato. Very nice to see you. Thanks for this splendid lecture. Some years ago, we saw a paper in Stroke and many others stating that aspirin actually would be protective for aneurysm growing and aneurysm rupture because of the inflammatory mechanisms. But patients that has a subarachnoid hemorrhage under aspirin has a larger and more dangerous hemorrhage. So what would be your policy for patients that are under antiplatelet, under aspirin because of all the reasons? Because it became very common nowadays. You know, patients come to us taking aspirin already because it was introduced as a prophylaxis by the neurologist, the general practitioner. And what would be your advice and why?
Yes, sometimes statin and also the aspirin, but it's I do not know the details why the aspirin can use for the how do I say the wall make a strong, but it is statistically. It is said aspirin and statin is the two is a very good. But we need some more, I think, study, the further study before the drugs, I think. Thank you.
Thank you. Yoko, we did a little study on aneurysm wall as well. And in ruptured ones, they were macrophages A. In unruptured ones, they were macrophages B. Do you think that we could use this for something like prediction of rupture? I have no idea how to diagnose this in advance, you know, beforehand.
Yes. Because this research work, how it's useful for the patient. So because we have so many unruptured cases in Japan, so sometimes we take some the piece for the sending to the pathologist, but sometimes there are very less macrophage infiltration. Those the wall and small.
Okay. Anyone else?
Now I say something, Vlad.
Yes, please.
Madam, thank you for this beautiful talk. And thank you also for highlighting the importance of looking at the wall dynamics and the features of the wall pathology when we talk about unruptured aneurysm. Because these days, when we talk about the risk of rupture, we focus on so many other things, including the size and other factors. But do you think in course of time, this enhanced MRI scan and the flow dynamics should be part of a investigation to predict the risk of rupture, especially when we talk to patients about it, and should be part of a routine workup?
Yes, not all the hospital, but at least some university level, I think MRI, we use enhancement for the rupture case, especially the large type of the aneurysm. So I think one of the routine work is very important for prediction for a rupture case, especially. Then we can talk to the patient family.
Yeah.
Yeah.
Thank you.
Okay, okay. Thank you very much
you.
for a
Thank you.
great lecture, as
Thank
always.
you. Thank
We
you.
enjoyed that very much. And I now would call for Professor Soichi Oya, who will
Yes.
continue with aneurysms, its effectiveness and limitations of bypass in the treatment of giant cerebral aneurysms. Soichi, please.
Okay. Okay. Thank you for the introduction. Okay. Let me see. Can you hear my voice?
Yes.
Okay. I'm gonna start my lecture. I'm very glad to be able to take part in this great seminar. And my talk is about the giant cerebral aneurysms. Just a minute. Okay, just a minute. It's not good. Okay, giant cerebral aneurysms are hard to treat. Previously, incomplete occlusion was reported to occur in 11%, and the neurological deterioration also occurs in 22%. What's more, surgical mortality is reportedly higher than 10%, even with expert hands. And so let me share the surgical complications we have unfortunately encountered so that you can take it to improve your surgical outcome. Well, first, I'll show you a case of an ischemic complication due to distal hypoperfusion. The patient had a ruptured left PCA giant aneurysm, and the thrombus in the aneurysm was extremely hard and difficult to remove during surgery. And during removal, which took a long time, a large amount of backflow was observed from the distal PCA. So we thought that distal bypass was not necessary. So simple trapping was performed. However, lobar infarction like this occurred. This case showed us that when trapping an aneurysm, it's important to secure distal blood flow as much as possible by revascularization technique. The effectiveness of bypass is already widely recognized. In addition to the usual STMC bypass, long distance and complex bypasses like these are sometimes necessary. A bypass is useful to increase the safety of temporary occlusion of aneurysms during obliterating aneurysms. Also, when conventional clipping is difficult, the key to lowering complications is to make the full use of bypass surgery to achieve indirect occlusion of the aneurysm. Here is another case of a complication that caused ischemic stroke. This is a case of a recurrent ruptured partially thrombosed ICPC aneurysm, which resulted in a distal embolization due to repeated temporary closure and recanalization of the parent artery during the procedure for repeated clip changes. The hypercoagulation status may have another impact. Whenever we temporarily close the parent artery, we have to be careful to prevent the migration of clots in the aneurysm to distal arteries. Thrombosis particularly makes simple clipping difficult or impossible. And furthermore, partially thrombosed aneurysms of the ICA are at much higher risk because of the need to remove clots, although we cannot necessarily occlude the surrounding arteries like an anterior caudal or PCOM. This is a case of ACOM giant aneurysm presenting with cognitive dysfunction. Look, this aneurysm appears to have a narrow neck. You may think that you may be able to insert clip to the neck, but we must assume that the wall of aneurysm neck, probably thick and hard, it also might be partially calcified. So my plan was using A3 bypass, followed by left SCA RA distal A3 bypass. If the conventional clipping appears possible based on my observation of the aneurysm wall during surgery, I may consider it. If not, I plan to trap the aneurysm. So now, first, I'm harvesting the RA graft. Then I prepared the STA. After craniotomy was done, I created wide working space by resecting the forks. And this is the A2, the frontal anterior skull base. This is the A3 portion over the corpus callosum. Now I'm preparing the A3 bypass. You see, this is the corpus callosum and the A3. Well, to achieve A3 bypass, of course, you must practice deep bypass technique. You also have to ensure that the surgical field is not contaminated with blood coming down from shallow to deep areas. As you see here, I'm having a clear working field. Some might say that we should not pinch the arterial wall with micro forceps like this. But in my opinion, it will be okay to pinch the portion outside the anastomotic site. I conducted the running suture in the center line, and I used the interrupted suture on the another line. And then the good patency was obtained. The ICG video angiography showed good anastomosis. And then I cut the radial artery, and using this radial artery graft, I connect from the A3 to the STA using this free RA graft. The difficulty with this bypass is that there is not enough space to lay this thick RA graft. But using the carotenoid and relatively wide exposure, I think you can do this bypass, thick artery bypass in the deep field. And then I anastomose the RA and the STA. And then I approach the aneurysm. This is the right side A1, left side A1. I put the clip both to the both A1, and I incise the aneurysm. And during the aneurysmectomy, there was a small amount of arterial bleeding. This is the backflow from the A3 bypass. And the condition of the aneurysm wall at the neck is not, feasible. It's not amenable for simple clipping. So I just trap the aneurysm. And RA graft was fine. And at the end of surgery, we repetitively confirmed the sufficient flow by ICG-VA and Doppler sonography. However, the postoperative angiography showed the occlusion of the bypass. We speculate that this is because the compression to the graft by the repressed bone flap. After this case, we began to dig a groove in the skull to accommodate the thick bypass graft. I show this technique later. But luckily, he had a good amount of collateral flow from MCA and PCA, possibly due to chronic hypoperfusion of distal ACA. He had no infarction in the distal ACA area and returned to home in a stable condition. The next case is a giant serpentine M1 aneurysm, larger than 8 centimeters, causing light hemiparesis. To our surprise, during his admission for elective surgery, he suddenly collapsed in the hospital ward. CT scan showed bleeding from the aneurysm. It was a slim hole, but we conducted emergency surgery. Our plan was like this: splitting the STA into 2 parts, this part and Y shape, and connect them with RA graft, and making 2 anastomoses to the distal STA as a Y-shaped graft for M2, then trap the aneurysm. So after opening the dura, first thing we needed to do was to remove the clot. You see, this is the aneurysm wall. And these are the distal arteries, which corresponds to the M3 of inferior and the superior trunk. Now I'm securing the proximal portion of the aneurysm, optic nerve, the ICA. I confirmed that I could use the temporary clip. And then I harvested the STA. And again, I harvested the RA graft. And we connect these 2 portions. I mean, we lengthen this portion using the free RA graft. This is a Y-shaped graft, which used to be the distal portion of the STA. And I anastomose the RA graft and the proximal portion of the STA main trunk. And then I connect this Y-shaped STA distal portion to the distal end of the RA graft. By doing this, I could, lengthen the STA to reach this portion, which is the distal portion of the M3 trunk. And again, I tried to keep the clear operative field. However, this portion, it's aneurysm, so it's very hard. So it was not easy. However, I could make 2 anastomoses. And intraoperative ICG-VA confirmed the patency of both bypasses. So I put the temporary clip, the permanent clip to the M1. A1 and C1. And I occluded the distal, the portion just distal to the huge aneurysm. However, possibly due to the initial damage of subarachnoid hemorrhage, he suffered from a bilateral MCA infection. We could not expect this. Although the aneurysm was obliterated, the aneurysm was not good. The outcome was not good. So this time, learning from our previous experience, we made a little change, which is gathering for thick radial artery graft, as shown here, to preserve the patency of bypass. The risk is also high if the trapping range includes small important branches such as PCOM or anterior coronary artery, as I stated. In this case, we first conducted IC ligation and the high flow bypass for this large right ICA aneurysm causing visual deficits. And on postoperative MRI, the aneurysm appears to have successfully disappeared. In fact, however, the aneurysm continued to grow with partial thrombosis. Since the risk of rupture was high and we could not use a high flow diverter, a flow diverter, so we decided to do direct gripping. And we were concerned about the persistent bleeding during aneurysmectomy. So we used the combination of endovascular surgery. Before surgery, we asked the endovascular surgeon to occlude the PCOM, which was located in the behind of the aneurysm. You see, this is the anterior caudal and the perforators from the IC top. During the aneurysmectomy, the bleeding was nicely controlled because the PCOM behind the aneurysm was already occluded. All the backflow bleeding was from anterior caudal. So the blade of a clip was inserted below the anterior caudal, which was a distal clip, and already applied another clip to the proximal ICA. This is a PCOM. You see the coil protruded outside the PCOM, and I put the clip here, and I confirmed the patency of this perforator from the PCOM. The aneurysm was obliterated, but a small thrombic infarction occurred, possibly due to the occlusion of the PCOM perforator that was patent during surgery. This issue I call terminalized perforator will be discussed later. The anterior coronary artery territory was preserved and the patient returned to her normal condition before surgery. The last case is a pediatric case, 2 giant MCA aneurysms in a row causing ischemia, presenting with hemiparesis and aphasia. 2 giant aneurysms present in a row in the MCA superior trunk. Today, I'm not going into the indication for direct surgery, but our endovascular team told me that endovascular treatment is not feasible. So this is a scheme of this surgery. We decided to anastomose the bypass to the M3 superior trunk, distal to the aneurysm, and trap the 2 aneurysms together. However, there was one concern with this strategy, which is the issue of terminalized perforator. If we apply a clip here, it makes this big perforator from the M2 will become terminalized, which increases the risk of delayed occlusion. I'll show you how it went. So this is a pediatric 6-year-old boy. So the CBM fissure was extremely tight. And this is ICA, anterior caudal, PCOM. And this is M1. But I couldn't see the distal portion of the M1 because the aneurysm was so big. Like this, I couldn't see the M1 distal portion. So I applied a temporary clip to the ICA, and I used the bipolar coagulation technique to shrink the aneurysm. By doing this, I could get the good exposure of the distal portion of the MCA, I mean M1, and also M2. So after securing the proximal portion of these 2 aneurysms, I move to the distal portion of the aneurysm. This is the M3 portion of the superior trunk, but the STA was too small, as you see here. So again, I had to use the radial artery graft for this 6-year-old boy. And this time I used a main trunk, long main trunk of the STA. And I used the radial artery graft to lengthen this graft. And then the bypass procedure is simple and the same as I presented. So I always, try to give a good counter pressure when I pass the needle through the arterial wall. And see how I use the carotenoid to stabilize the graft. And I use a copious irrigation also. Even a small clot can increase the risk of acute occlusion of bypass. So the bypass part was done. So I applied the clip to the distal portion of M2 trunk. This is the distal, the second aneurysm. The first aneurysm is behind the second aneurysm. And first I applied the temporary clip to the ICA again. And I approached the M2 superior trunk. This is M2 superior trunk, and the perforator, originated from here. And I apply a clip between the perforator originating site and the proximal neck of the aneurysm to trap these two aneurysms together. And we use the MAP during surgery. And the perforator was patent, and the MAP was fine. And the distal bypass was working. And the postoperative CT scan looked good, and the boy had no paresis after surgery. And the postoperative angiography also showed the preservation of you see the perforator, thick perforator, and the disappearance of the aneurysm. However, on day 1, he showed worsening right hemiparesis. MR imaging demonstrated a new infarction in the territory of the perforator. But he eventually showed a good recovery with no neurological deficits. CT angiogram obtained 6 months after surgery showed complete obliteration of the aneurysm and growth of bypass. So today I talked about the surgical nuances for these aneurysms, and we should make the most of vascular reconstruction, and we should be familiar with multiple clipping technique. And we also have to prepare for the sclerosed thrombus. But no matter how we tried our best, but it's still difficult to overcome delayed occlusion of terminalized perforators. Thank you for your attention.
Vladimir, perhaps Giovanni, you are the chair. Giovanni, if you unmute yourself. Unmute yourself, Giovanni.
Okay, you hear me?
Yes.
So compliment for this wonderful presentation, and I think that the conclusion, the suggestion that you go for a young neurosurgeon is very, very important, very complicated, topics, but there is the solution that you proposed. There is anyone that want make comments or ask questions? If not, only small question. You say that in this case of the boy, you use the radial artery. Do you think that this, let's say, invasive way to find out the method of the bypass has to be limited, or is to be more? There is more option. And second things, do you think that the venous draft there is still any place of that or not?
Okay, thank you for asking. As for your first question, we were not sure that if we can use the radial artery graft over a 6-year-old boy. This was my first experience. So our first plan was to use the STA. However, it turned out that the STA was too small, and it would not be able to cover whole territory of the MCA. So we just our own intraoperative judgment. That's all. Yeah. To complete, to save his life. And the second question, we prefer arterial graft because we believe that it's more physiological. However, I'm sure, I think possibly even with expert hands, I think the same result will be obtained. But we are just used to using the artery graft.
Okay, thank you. Any other comments? If not, thank you. And we pass.
Thank you.
And we pass to the next speaker, my good friend Bing Sung. Are you ready?
Yes.
Okay, go ahead.
Okay. Thank you, Professor Roach. And today my topic is measurement of pressure during moya-moya vasculopathy surgery. So classification of the bypass from a hemodynamic perspective. The first type is flow preservation. The ECIC bypass for complex aneurysms usually combined with the proximal arterial occlusion, sometimes also use distal occlusion. And malignant score-based tumors, such as nasopharyngeal carcinoma, invading the ICA and require the resection of the ICA to complete resect the tumor. The second type is borrow blood flow from neighboring blood vessels. It's ICIC bypass. For this kind of bypass, one proximal branch was closed, so totally blood flow is decreased. The third type is flow augmentation, the bypass of the moya-moya vasculopathy that directs blood flow from the ECA branches into the ischemic vascular network of ICA. This is a demonstration for the flow preservation. This is the highest flow bypass. This is a nasopharyngeal carcinoma. It invaded both sides of the ICA. So we have to replace the both sides ICA for the whole brain. So for this kind of condition, the blood flow demand was the highest. So I use saphenous vein as a graft from ECA to saphenous vein to M2 segment. Makes a direct bypass. And I also add 2 STA to M4 segment double bypass. So with these 3 bypasses, you can see we occluded the both side ICA, and the blood flow was enough for feeding the both side ICA. The second type is a borrow flow from neighboring blood vessels. This is a ICIC bypass. This is a A2 to A2. So the flow augmentation bypass is mostly for moya-moya vasculopathy. So this is a single bypass, double bypass. And I always use STA or post-auricular artery or occipital artery to MCA or ACA or APCA bypass combine the EDMS. So the purpose is to allow maximum use of the 3 arteries. So the skin incision, bone flap, dural, and the location of the bypass was all designed personally. So this is the best possible outcome. You can see the both side ICA was totally occluded, and the both side hemisphere was totally fed by the ECA branches. Sometimes even one single STA MCA bypass can feed the whole hemisphere, even the contralateral frontal lobe. But in most cases, there's some competition between ICA and the ECA flows. So for moya-moya vasculopathy, you can see after the long-term follow-up of the 3D DSA, you can see the ICA will still have some blood flow for the PCA territory, and the most of the MCA territory now fed by the ECA branches. And there's some watershed between the ICA and the ECA. So this watershed is a 3-dimensional curved surface formed by the pressure equivalent points within the blood vessels. So according to Poiseuille's law, the delta P is the only dynamic factors that determine the directions of the blood flow and the drive blood flow. So you can see after the direct bypass, this is a 4D DSA. You can see the blood flow come to M2, then redistribute the blood flow along the MCA territory. But the ICA still have some blood flow. This is another 4D angiogram for ECA. You can see the blood flow come to the moya-moya vessel segment. So the determinants of the degree of the reconstruction of the cerebral blood flow depends on the choice of the surgical approach, and it depends on the severity of the moya-moya vasculopathy. In different stages, ICA residual blood flow pressure is different. Sometimes it's still powerful. It finally depends on the pressure balance of the blood flow of ICA and ECA. So this is a distal MCA network. You can see after the blood flow comes through the moya-moya vessel networks, the distal MCA velocity and the pressure of the blood flow was decreased a lot. So this is just like the slope. One of my Chinese colleagues, Professor Li Conghui, he put some stent in this moya-moya syndrome. You can see when she putting the guide wire and put the stent into the M1 to M2, then the blood flow was reopened, and you can see the moya-moya vessels shrinked immediately. If you look this kind of from right to left from this direction, actually it's progressive of the stenosis and the occlusion of the M1, and the moya-moya vessels was increased a lot. So the delta P is the only force that drives blood flow. This is an example. You can see in the distal part of the vertebral artery to the junction of the basilar artery to the another side, you can see this segment, although it's very thick blood vessel, but the blood volume was 0 because delta P is 0. So now I will report the pressure measurement of the molar bypasses. It couldn't be complete by the ICA-MCA pathway because it can be only done intraoperatively. This is a pressure wire. So this is an accurate measurement result for the first time. We separated the two branch of STA, one as a monitoring window, and we can get 7 pressure parameters at the same time. The pressure 1, pressure in STA when the stoma is closed. Pressure 2, STA when the stoma is open. Pressure 3, pressure in STA when the flow goes to the distal part of the stoma. Pressure 4 is STA pressure when the flow goes to the proximal part of the stoma. So the pressure 5, 6, 7 was about the recipient arteries pressure. Pressure 5 is the pressure from the distal part of M4 reflux, and pressure 6 is the pressure from the proximal part of M4, and the pressure 7 is when the stoma was open and the blood flow reflux to the STA, we measure the pressure as P7. So we also measure the 2 different partial pressure of oxygen in donor blood flow and in cortical blood flow. This is the result in 42 cases. In 17 cases, we found the second type of MCA pressure gradient, indicating the reverse flow in MCA area. This is the donor pressure P1, pressure in STA when the stoma is closed. When the stoma was open, the pressure P2 can be decreased because the blood flow velocity was increased a lot. So according to Bernoulli's principle, the pressure can be decreased. This is the recipient pressure 5, pressure of the distal part of the M4. When the STA was closed, the pressure reflux to this segment of the STA, we can measure the distal part pressure. This is the proximal part pressure. And this is the stoma's pressure. So this is the final result. You can see in 17 cases, 40.5%. The PMCA distal was larger than PMCA proximal, indicating the reverse flow in MCA territory. So the mean delta P from STA to recipient artery was 43 mmHg. And this is a STA. When we remove the clip from here, the blood flow going faster and faster, then the pressure in the donor artery can be decreased. So this phenomenon complies with the Bernoulli's principle. This is a result of P3 and P4 when we let the blood flow go to the single branch of the recipient artery, you can see when it's going to the low pressure part, the velocity is faster and the pressure around here was lower than that going to the higher one. Going to the higher one, the pressure was higher, and also means the blood flow was slower according to Bernoulli's principle. So going to the, if we let the main blood flow going to the lower part, it's more reasonable. So the data of the partial pressure of the oxygen, this is a different. This is a difference in the STA under the recipient artery. The mean that P oxygen is 27.63 mmHg. So the data P in donor and the recipient artery is equal to 57 centimeters water column. It's just like a little waterfall. So the measured results also showed two pressure gradient of the MCA network. The first pressure gradient of the MCA, it's occupied around 60%. Still keep the physiological direction. The P proximal is larger than P distal. But also we have 40% of the second pressure gradient of MCA. It's a reversed physiological direction. P proximal is less than P distal. So this is the rationality of parallel bypass, which means the direction of the main blood flow in the donor artery keeps the same gradient of the MCA. So the blood flow, if the two pressure gradient was keep the same direction, this is can achieve the better result. We already published this kind of result, but now we can make sure because we can find the pressure gradient was approved. So when we check the blood flow at the stoma, normally it's a bidirection blood flow to both sides, to distal or proximal. But if we change the injection angle, we also can change the blood flow partially. So the distribution of the blood flow can be partially determined by adjusting the injection angle. And the Q was also inversed proportion to air of the length of the donor artery. So by adjusting the length of the donor's vessel, the blood flow distribution can be also adjusted to cortex with different ischemic degree. Like this frontal lobe need more blood flow. So we give the patient one shorter and bigger donor artery. But this is a temporal lobe need less blood flow. So we give it a longer one and a smaller one. The short and the straight donor transport efficiency was higher. In this right picture, you can see the both side donor artery carry on similar amount of the blood flow. So this is a preliminary result of the measured pressure. In donor artery, STA pressure is high, close to mean artery pressure. After anastomosis, the blood flow increased. The pressure gradient is reconstructed, and the pressure is reduced, which is in line with the Bernoulli's principle. In the recipient artery, in line with the slope principle, The pressure of the distal M4 is significantly reduced after passing through the moya-moya vascular network. The pressure gradient, distal blood flow pressure, and the proximal pressure are not the same. Two pressure gradient for the MCA network are proved. There's around 40% is presented as an inverse pressure gradient opposite to the physiological direction. A parallel bypass keeping the same direction of the primary flow in the donor artery as a recipient pressure gradient is reasonable. Between the donor and the recipient artery, the pressure difference is significantly. Average 43 mmHg, which means 57 centimeter water column. It's just like a small waterfall as high as your knee. After bypass, the pressure gradient was reconstructed to form a new ECIC watershed. It is inevitable. Between donor recipient arteries bloodstream, there was a significant partial pressure difference in oxygen, average around 27.6 mmHg. This is essential for the formation of the indirect anastomosis. So the more you know, the closer you can get to the goal. Thank you. That's all for today.
Thank you, Vincent, for this wonderful presentation. And that is bringing us again to the physiology of the perfusion of the brain, and not only, as often happens, a kind of hydraulic approach to the malformation of artery problems. There is any comments, any question? If not, we thank you. We proceed to the next one, which we changed the subject from the vascular malformation to the tumors. And it's a pleasure to introduce Takeo Goto. We talk about the approach for large Petroclival meningioma. Please.
Thank you. Can you see my slide?
Yeah.
Okay. Good afternoon to European neurosurgeons, and good night to Asian doctors. Today, my topic is a minimum anterior and posterior combined transpetrosal approach to large petroclival meningiomas. Our institute, Osaka Metropolitan University, is one of the large skull-based centers, so we operate many petroclival meningioma. And our old mentor, Professor Hakuba, introduced a combined transpetrosal approach to petroclival meningioma. And my mentor, Kenji Ohata, and I follow his technique. I know that this approach is very effective for safe resection of the petroclival meningioma like this. But in this approach, exposure of the sigmoid sinus and drill out the petrous bone in narrow surgical corridor seem to time-consuming and complicated procedure. So now many doctors hesitate to use this approach, and many doctors prefer to use suboccipital approach to petroclival meningioma. So I modified this combined transpetrosal approach to shorten the surgical time and to increase the safety of this approach. At first, I modified the surgical technique, especially expose the sigmoid sinus. From our surgical experience, I found that the wall of sigmoid sinus just adhere around the mastoid emissary veins. So if we meticulously drill out the bony structure around this emissary vein, as a part of the sinus wall can be safely dissected from the inner surface of mastoid bone. So recently, our resident exposed the sigmoid sinus under macroscopic fashion in just 10 minutes. It's very useful technique to expose the sigmoid sinus. Then we have to drill out the petrous vein, petrosal bone, but we should not drill out the petrous bone in narrow surgical field. At first, we should dissect the dura mater around the middle fossa and pre-sigmoid space to wide exposure of the petrous bone. And then I just drill out along the petrous ridge. So the amount of bone drilling is very small, and bone work is very short time. This bone work looks like the drilling of the sphenoid ridge in case of terional approach. So this is a simple illustration showing our surgical procedure. At first, I just put the temporal craniotomy and drill out the outer plate, remove the outer plate of the mastoid bone, and expose the sigmoid sinus in macroscopic fashion. And then we start the petrous drilling, but we just drill out along the petrous ridge. The purpose of this drilling is to expose the superior petrosal sinus from posterior to anterior to the Meckel cave. Why we have to expose the entire course of the SPS? The reason is that we should cut the SPS, most anterior side, to preserve the venous flow from the petrosal vein to superior petrosal sinus. So this dot line indicates how we cut the dura mater. So bone work is limited around this area. So surgical time is very short. And then we open the Meckel cave at the initial step of the surgery. This is another key step of this approach. After opening the Meckel cave, we can mobilize the trigeminal nerve upward to enlarge the surgical corridor around the CP angle. If we cannot identify the 6 or 7 8 nerve, we additionally drill out the petrous apex in the subdural space. I will show our surgical technique in this case. This Petroclival meningioma causing the severe gait disturbance to her. So we decided to use the right minimum combined transpetrosal approach. I cut the skin like this. The size of skin incision is not small, but it's for harvest the temporal fascia with a pedicle of sternocleido mastoid muscle. But craniotomy is very small. We just perform the temporal craniotomy and drill out along the mastoid emissary vein under macroscopic fashion like this. And then we harvest the outer plate of the mastoid bone like this. This procedure completely performed under macroscopic fashion. So our resident carefully dissect the wall of sigmoid sinus. Then entire course of the sigmoid sinus was dissected. And then we move to the microscopic procedure. At first, we expose the pre-sigmoid dura like this and carefully dissect. We cut the endolymphatic sac. Now, petrous bone was widely exposed, but bone work is just around this area. Just drill out the petrous ridge is enough to resect the petroclival meningioma. And then I cut the dura under the SPS from posterior to anterior side. Then I open the Meckel cave at the initial stage of the surgery. This is a trigeminal nerve. And then I carefully open the Meckel cave like this. And also I cut the tentorium around the posterior side. This is a horse nerve, and this is the trigeminal nerve. At first, this space was small, but I carefully coagulate and perform the detachment of the tumor. This is the attachment, upper part of the tumor. And then I widely mobilize the trigeminal nerve. And then I additionally drill out the petrous apex to identify the sixth nerve. So a bone work is can be done in short time, and I identify the sixth nerve. And also continue the detachment of the tumor. Now all part of the tumor was detached. So when we perform the tumor removal, we not encounter the bleeding. And then I carefully mobilize the trigeminal nerve, trochlear nerve upward, and then I gently pull the tumor downward very carefully. This is the final attachment of the tumor. I cut and detach the tumor. So easily dissect from the vascular artery, and all tumor was safely dissected out through the around the Meckel cave. So finally, all tumor was successfully resected out. A tumor was totally resected out, and her gait disturbance improved. But one of the disadvantage of this approach, patient shows a numbness of hemiface because we widely open the Meckel cave. This is another case of the large petroclival meningioma. Attachment is wide, and also tumor embed to internal auditory canal. But we use the same procedure. At first, I open the Meckel cave. This time, this part was severely calcified, but I use the QSAR and cut the tentorium and open the Meckel cave and start the detachment of the tumor. This is the fourth nerve, and I perform the detachment of the tumor and expose the third nerve. This case, attachment of the tumor is wide, so I additionally perform the bone drilling and then open the internal auditory canal subdural space. So surgical time of bone work was very short and small time. So I carefully dissect the tumor from the eighth nerve, and also we carefully mobilize the tumor like this. At this time, already tumor was devascularized. So we can safely and easily rotate the tumor from brainstem and trigeminal nerve. Like this. Detachment of the tumor is very important. So we can safely mobilize the tumor from the brainstem and SCA. So now I dissect the tumor from the vascular artery, and most part of the tumor was successfully resected out, like this. This is a sixth nerve. This case also, patient shows a numbness of right hemiface, but her gait disturbance and dysphagia completely improved after the surgery. This is another case of the very large petroclival meningioma, also occupies the Meckel cave. But our surgical procedure also same. We make the skin incision like this and harvest the temporal fascia like this, and perform the temporal craniotomy, and then also harvest the outer plate of the mastoid bone like this. Sigmoid sinus was exposed under macroscopic fashion like this. And then we start the microscopic procedure. Our procedure also always same. At first, dissect the middle fossa dura, and then dissect the presigmoid dura for wide exposure of the petrous bone, like this. And then I just drill out along the petrous ridge, and then open the Meckel cave. Small bone work is enough to open the Meckel cave. After open the Meckel cave, we devascularize and detach the tumor like this. Then we mobilize the tumor from the brainstem. Tumor was very large, but most part of the attachment already detached. So we can smoothly mobilize the tumor from brainstem and also SCA like this. So we can safely dissect the tumor from the brainstem. I additionally drill out the petrous apex to identify the sixth nerve, but this bone work was performed in subdural fashion, so it's relatively easy to drill out the anterior part of the petrous bone. And now I dissect the tumor from basilar artery, and most part of the tumor successfully resected out like this. This is another case of the large petroclival meningioma on the left side. But our surgical procedure always same. At first, I carefully dissect the presigmoid dura and also dissect the middle fossa dura and expose the petrous ridge, and then just drill out along the petrous ridge. In our bone work, no need to open the internal auditory canal, and also no need to identify the semicircular canal. And then I open the Meckel cave at the initial stage of the surgery. So now most part of the tumor detached. So the color of the tumor changed the bloodless. So we can easily mobilize the tumor from the brainstem and carefully dissect the tumor from basilar artery and its perforator, and then dissect the tumor from brainstem. So the tumor around the posterior fossa decompress, and then we move to the tumor around the posterior cavernous sinus. I carefully dissect the tumor from the beacon and third nerve and fourth nerve. And finally, most part of the tumor was resected out like this. This tumor also resected out safely. This is a summary of our surgical result to large petroclival meningioma. The size of tumor is large, but extent of tumor removal is sufficient. Of course, the many patients shows a numbness of hemiface after the surgery, and also patients shows some transient diplopia, such as abducens or trochlear nerve palsy. But in all cases, this diplopia disappeared within the 3 months follow-up period. And one of the most benefit of this approach is we not cause the facial palsy after the surgery. So I think our minimum anterior and posterior combined transpetrosal approach is very useful procedure for large petroclival meningioma. And surgical time and bone work is not so long compared to the suboccipital approach. So I think this is a very useful procedure. We published this technique to JNS last year. So if someone interested to this approach, please check paper. We include a video clip, how to drill out or how to expose a tumor around the Petroclival junction. Thank you for attention.
Thank you, Professor Goto. It was a wonderful presentation for this, let's say, modified, very small and less invasive approach. And I think that Professor Kato, if you hear me, would be very happy of your presentation. There is any other question, comments about?
I ask something, Giovanni.
Please.
Prof. Goto, that was a beautiful talk and the beautiful technique. I mean, we know that with the Petroclival approaches, often the concern from a surgical side is the amount of time we take. You know, some people try to do it in 2 stages. And how much of time you think you would get benefit from minimizing this Petroclival approach in terms of reducing the amount of time?
Thank you for attention. Thank you for question. If we apply this procedure to large Petroclival meningioma, of course, the surgical time takes 7 hours or 8 hours because the subdural procedure is very meticulous. But bone work is not so different to the suboccipital approach.
Okay.
So we can finish the operation at the PM6 or something.
Okay.
Any other comments? Questions? Not. I think you were very clear and fascinating on this presentation. Thank you very much.
Thank you.
And we proceed with another presentation on paracellular lesion. Professor Kenan Arnautovic. Kenan, it's your time, please.
You're muted, Prof. Arnautovic.
All right, good morning. Can you see my slides?
Yeah.
Yes.
Yeah,
Okay.
before you start, Kenan, I just want to say a few words. First, thank you very much for having the effort coming directly from Cairo back and join us at the webinar, and you have surgery today. And Professor Kenan is a known scout neurosurgeon, and he has trained in Sarajevo originally, and then he has double training actually in the US, and he is chairing the department there. And he is chairing many committees in the World Federation. I just want to say for people they don't know you by face, but at least by name. So please go ahead with your presentation. Thank you.
Thank you very much, Imad. First of all, I would like to thank Imad and Vladimir for a kind invitation. I would like to greet all of you, my colleagues and friends around the world. And special kudos and thanks go to Professor Robert Spessler, who is everybody's mentor in the world, whose work we admire and celebrate today, and who placed high standards at our research and presentations. I'm going to talk about a topic that's dear and near to my heart, and I'm going to talk about preservation and improvement of vision in paracellular lesions. Is that possible? I have no commercial disclosures. And in my practice, I am encountered, like all of you, many of these tough cases which alter vision. And I tried to find the way what is the scientific way? Is it preservation and improvement of vision after surgery happens randomly? Is there some science in it and all that? So first, what I went to the literature and looked, I mean, is there any in the literature information about vision improvement? And it's all over the place. These are some of the studies I took out, and you can see that it's all over the place, vision improvement range. Roughly 50% people report improvement. But what does it depend on? Does it depend on the preoperative function, status of optic nerve retinal cells, length of preoperative deficit, size of tumor? Is it different in meningiomas, pituitary tumors, or craniopharyngiomas? What kind of surgery? How do you quantify it? What do you need to do to preserve vision? Is just to go and operate and with no strategy and be careful? So what do we know? We know that most common lesions, as I said, that impair vision in stellar parasenal areas are pituitary tumor, meningiomas, craniopharyngiomas, aneurysms. What does cause optic nerve impairment is direct compression of the tumor or aneurysm, vascular impairment inside the optic nerve, or combination. And then what are the points of tethering? You know that there is arachnoid fibers around the optic nerve and chiasm that are tethering the optic nerve. We know there is falciform ligament. These are beautiful studies of Roton. We know that there is clinoid, and we know that there is optic canal. So obviously optic nerve is tethered in the canal. It cannot move because it's stuck, you know, very simple mechanical thing. And you can see here falciform ligament and optic nerve sheath. And what do we know? We know the optic nerve segments. We already know them from beautiful studies of Professor Roton. So, you know, I am pretty kind of straightforward, which I learned from my mentors, cranioorbital craniotomy, pretemporal approach, removal of the roof and lateral wall, opening of superior orbital fissure, opening of the lateral wall, extradural removal of the clinoid, opening of cistern and falciform ligament. And I've been doing it for years. And I've noticed that my patients really do well after surgery with not only preserving vision, nobody has it worsened, but also improving it. So I was, these are all the steps of my technique, and we all know them very well, and I'm not gonna dwell. One point of is that gel foam powder balls are the best in controlling of the bleeding from the cavernous sinus in my hands. Sometimes I use Dr. Krish's recommendation of TUSIL, but gel foam powder much better. So anyway, we learned from how to remove clinoid, anterior clinoid extradurally. We learned how to, from Professor Almefti, Professor Yasharil, how to open the arachnoid membrane, cisterns, etc., etc. But the scientific proof of all this has been lacking. So, you know, I spoke with my residents about how to prove it. What do we do to show that if we decompress the optic nerve, the pressure decreases, that the size of the space increases, etc. And my residents, very smart people, much smarter than I am, told me it's very simple. You just measure the pressure after each step, and they showed me how. So we did. These are all my senior residents, and this is published online in February, coming in operative neurosurgery. So if we first looked at the falciform ligament, what do we cut? You know, we want to know what do we cut, and it's fairly similar, yet thinner structure than the dura. Then we looked into vascularization. This is very, very interesting finding, has not been thoroughly looked into. So there are several parts of the optic nerve. One is, you know, as you know, proximal canalicular and falciform segments. And here is, you see how the vascularization is very sparse. You see here, there are few blood vessels. This is ophthalmic artery getting into the adjacent to the optic nerve from the carotid artery. And you see how there is central network, but not very rich. It's not abundant. And probably optic nerve in this segment gets from spinal fluid its nutrition. But look distally, when it goes beyond the optic nerve canal, look how rich vascularization, abundance of longitudinally capillaries, transverse capillaries, central artery. So here it gets fairly significant vascularization. So pattern of vascularization completely different. So it's like thoracic spinal cord. You know, there is a T1, T3 transitional area that's relatively poorly vascularized as opposed to cervical and lower thoracic. And this is the area where this is most sensitive area of the optic nerve vascularization wise. So what we did is basically we took a string, placed it around the optic nerve, and measured the pull pressure superiorly with upward dislocation and lateral dislocation. We first opened and released the arachnoid membrane in cadaver specimens, And we used the manual tensile gauge produced in Carolina Biological Company in Burlington, North Carolina. And we measured the pressures. This was the stage 1 of our experiment of our project. Stage 2 was after opening of the falciform ligament. We did lift it with a nerve hook and cut with a sharp knife, and then measured the pressure again with upward pull and lateral pull. We also measured at each stage the distance between the carotid artery and optic nerve. And then as a final stage, because there is no release of optic nerve, not only by taking out the anterior clinoid, but as you know, we have 360 degrees to decompress the optic nerve in the canal to completely free and make it nice and relaxed, and release this vascular tethering and in this transitional, very sensitive zone, as I showed before. So here it is, we measure the pressure again. So in a nutshell, what happens, this shows, you saw these are comparison between cisternal falciform canalicular segments. And you see here, we always use the same force, but you see how the tension progressively declines and how the dip, the space between the carotid artery and optic nerve progressively increases. And then we compared, this is just a couple of tables to show our results. You see initial area 9.7 of optic carotid space. After releasing cisternal, increases to 11.9 after falciform, and after decompressing canalicular and clinoidal segment, it increases to 17 millimeters. It's almost double where it was. Same is with if you do upward mobilization, which obviously we recommend after the study because the pressure is much lower with upward dislocation than with lateral dislocation, probably due to the orientation of fibers of the optic nerve. You see how added area increases up to 30 square millimeters, which is huge, huge size of additional working space between the optic nerve and carotid artery. Now, if we compare here upward pull and side pull and between cisternal, falciform, and clinoidal, and this is again the same force used, but look, the dip is always much larger in favor of upward pull after all three. It's almost double, maybe even more in each stage of the dissection. And then finally, changes in this biomechanics. If we look side pull to side pull to side pull at cisternal and at falciform and intracanalicular mobilization, you can see here that again, the dip progressively increases, tension decreases, and the force used is the same. So I think, at least in cadaver specimens, and of course it's not always parallel to the human, we can say that this clearly provides, number one, relaxation of optic nerve. There is no doubt about it. Increases space between optic nerve and the carotid artery. And number three, obviously increases the vascularization or decreases the amount of vascular compromise. So I think all this is very beneficial in addressing these lesions in the paracellular cellular area. So I'll just give you a few samples. This is one of the cases that I did recently published in operative neurosurgery. You see the preoperative loss of vision on the side of the tumor, and which is obviously right side. And I'll just go briefly through some key points of this. So here is obviously coagulation of meningorbital artery, opening of the meningorbital artery. You see this is a metastasis of the renal cell cancer, and it's very vascular. You can see here we are opening lateral wall of the cavernous sinus, and obviously bleeding is present. These are the V1 and V2. Why is it important to do pretemporal approach? By the way, here is the usage of the gel foam powder. Why is it important to do pretemporal approach? They say, why do you do pretemporal approach? Because the opening of the removal of the anterior clinoid is extremely easier by doing this, as we expose anterior clinoid almost 360 degrees. So we are not digging in the depth to remove the clinoid. We are getting widely on the side of the clinoid and basically removing it. So so here is basically anterior clinoid being resected, and optic nerve fully decompressed, as you see here. And this is a final anatomy. You can see here all the elements, optic nerve, third, fourth, fifth nerve, completely resected tumor, and after optic nerve decompression. So you can see here how vision after gross total resection improved from almost blindness completely to here. So we can go on and on. I have a big series of cases. This is the left side osseous meningioma. You see here dense left hemianopsia. I'm not going to dwell on this video clip, but here you can see after surgery, compare pre-op, post-op, complete improvement. And here is she happy with improvement of her vision. Another case, look at this one, complete blindness with this large clinoidal meningioma. You see optic nerve on the right side improved about 75% compared to pre-op. You see here gross total resection. This meningioma was wrapping the carotid artery and bifurcation. This is a case removed by, in 2016, removed by a very prestigious neurosurgeon in the United States. Happened to come to me because there was a residual tumor and she was blind, presented with blindness, but was able to count fingers, so she was legally blind, but she was able to get around. And I saw here they did a beautiful resection, but left this part of the tumor that's the easiest part to remove. And what I did is basically removed this anterior clinoid, which was a virgin territory. They didn't go there. And I still don't understand why they didn't do this. And we preserved her vision. It was very, very simple surgery because I went from the virgin territory. This is another case that's coming in February with a patient that in operative neurosurgery, fairly large tuberculous cell meningioma. And you can see here, the patient is bilaterally blind for 3 weeks. And I told the patient preoperatively, there is really no chance that you can see again. But, you know, she could see waving of my hand and all that. And I told her, that's probably the best we can get. So this is approach. This is pretemporal approach. I learned this technique from Ali Krisht of retracting the temporal dura and frontal dura. This is the dissection of the sphenoid and basically drilling of the clinoid, drilling of the sphenoid ridge. You can see here always abundance of irrigation is important. Here is the removal of anterior clinoid. You can see here optic nerve already happier and completely decompressed. And you can see here, as I said, significant irrigation during. But it's not enough only to remove the clinoid. We got to go all the way and 360 decompress the optic nerve prior to any surgical resection, because that allows, when we manipulate optic nerve, not to hurt it. So just to progress, here is opening of the carotid cistern. You can see carotid artery and optic nerve. Now, there are two types of tuberculous cell meningioma. One's that you have to go between the two optic nerves. By the way, this is opening of the falciform ligament. I do it with a little hook and a sharp knife and relax the nerve. But what I wanted to say, there are tuberculous cell meningiomas that you remove between the two optic nerves mainly, or between the optic nerve and the carotid artery. So here I'm obviously devascularizing and keeping this tumor avascular while resecting it. You see optic nerve nice and relaxed and progressing with resection. Using CUSA, and here slowly delivering. Here is obviously you can see now the other side, the other carotid artery and optic nerve, and then we also go to the left-sided optic nerve. And open, you see the left-sided optic nerve, and open the falciform ligament over the left optic nerve, and eventually resect the tumor. So here is the final anatomy. You can see here the carotid artery. This is optic nerve. You see how it's nice and relaxed. And you can see here the genu of the carotid artery on the right side. Here is on the right, on the left side. So both optic nerves. You can see here the perforators, the carotid artery on the other side. And then here you can see the pituitary stalk. So it has always to be preserved. I think I have 2 more minutes. This is, by the way, postoperative complete resolution of vision on the left side and almost complete on the right side. Gross total resection. I just want to show real quick this one last tuberculum cell meningioma, a little bit smaller than the previous one. So here is opening of the falciform ligament. I also use sometimes the bent knife, sickle knife, and open it. And you can see in this particular meningioma, we work between the right-sided optic nerve and the carotid artery, because that provides us the access to the tumor in addition to between the 2 optic nerves. This is just dissecting the tumor from the complex of the ACOM and progressing the tumor resection. And you see this edit space with this removal and resection of the anterior clinoid, and you see the relaxed optic nerves where they really can take this dissection. Of course, important is to preserve all these perforators, as you can see here, and then resect the tumor. Just to show the final picture, you see we work under the brain, there is no retraction, and this is the postoperative visual fields that improved. I think I have 1 more minute to show just a few other. This is another tuberculum cell, almost complete resolution of almost complete blindness. Craniopharyngioma, same thing, improvement after surgery. Here also you can see blindness preoperatively, improvement after surgery, and so forth and so forth. At the end, I think that at least on cadaver specimens, we have proven this decrease in tension in the optic nerves with this stepwise dissection and complete decompression of the optic nerve. And again, I want to emphasize, look for 4 tethering of the optic nerve. Number 1, arachnoid membranes, arachnoid adhesions. Number 2, falciform ligament. Number 3, anterior clinoid. And number 4, 360 degrees decompression of the optic nerve in the optic nerve canal. Thank you very much again, and I'll be very happy to answer any questions or take criticism.
Thank you, Canon, on this beautiful presentation and convincing how we have to decompress the optic nerve around 36 degrees. There is any comments, Ivan?
Well, thank you very much, Kenan, for this wonderful presentation documented with images and visual acuity studies. I just want to draw your attention. You have mentioned that you can still be able to do the falciform ligament on both ends, both sides. So especially in tuberculum cell meningioma, when tumor goes in both foramina, then you can do this. If you are not seeing in full from the contralateral side, you still be able to do the falciform ligament decompression, the same technique you have mentioned. Wonderful presentation. Thank you.
Yeah, just one emphasize. I think another thing that we all need to keep in mind, it's important to use a good diamond drill, at least in my hands, which is, I use usually 2 millimeters with extreme irrigation all the time, because there is, Professor Dolenz was talking about this, I remember 30 years ago. There is a heat being transmitted from the drilling tip to through the bone to the nerve, not only the optic nerve, but third nerve as well. So you need to do significant irrigation all the time to avoid heat transmission, because that's the danger in these tumors, that you can transmit the heat. You do everything perfect, and you are wondering what happened. The nerve has been burned by this drilling. So,
yeah, thank you, Ken, and the very nice presentation. Beautiful the videos. Enjoyed it. There's one question and one comment. What's your view about the endonasal? I mean, you didn't address that. I don't think we have time for that, but just a quick thing. That's number one. And number two, we have been using this ultrasonic drill. You know, you talked about this heat generation. We find this is a little safer, close to the vessels and the nerves when we are very last bits of the bone. It takes more time than the high-speed drill. So we do the most part with a drill, high-speed drill, and then the last bits we take out with an ultrasonic, kind of drill. That's how we do it. But I really enjoyed your talk. And you're just a very quick comment about the endonasal, which I don't do. I don't think that's the correct way to do it, but I would like to know your views about tuberculosis.
So very simple. I'll go fast. I know we are waiting for the next presenter. Number one, you asked about the non-drill ultrasound removal. I think that is also option. I don't use it personally because I kind of got used to and comfortable with the drill. But I think everything that works is good, but it still releases heat, Passant. So you need to be careful the same way as the other problem. You know, it has a little curved tip, and I am always worried about the other side. You know, drill, you can see the drill, you know where are your margins of your dissection. That is a little bit cumbersome, at least for me. Regarding endonasal, I personally don't understand going through the nose to decompress the tuberculum cell meningioma. Why? Because with this in my hands and in many of your hands, I saw many videos from Imad and many other, you, Basant, as well. I mean, to decompress the meningioma, go through in the nasal approach, doesn't make much sense. Number one, this is 2-3 hour surgery. You have full control of all elements. If God forbid there is a problem with carotid artery, you put a clip, you reconstruct, you put the sun clip. You have so many ways to quickly fix the problem. Through the nose, in my mind, I do a lot of transnasal surgeries. I do pituitaries, I have large series and all that. But to me, going to the tumor, where at the end of the surgery, you will see all the arteries and you are pulling all the time. God forbid, when something ruptures, you have no ways to treat it, or very marginal ways to treat it. So, I've seen videos of people doing it, some great friends, Luis Gomez Amador, I've seen Denny Prevadel, all great friends, we discuss it. I personally don't, in my hands, it's not that I would do that way, but of course people are doing it and showing the results.
So thank you. I have just one question. You show us what is the pressure difference when you pull the nerve, the optic nerve around. There is an ophthalmic disease that is the sufferance of the optic nerve in the eye without any pathology, intracranial pathology. do you think that the compression of the nerve may be resolve that?
Are you talking about pseudotumor cerebri?
Yeah.
Okay. Well, I think that, by the way, I hate pseudotumor cerebri. I always try to dump the patient on some of my partners, because it's so difficult to hit the ventricle with the catheter. They are so small, and then you need to do lumboperitoneal shunt and all that. But yes, ophthalmologists are doing the compression, and I think this is one of the way. By the way, I gave this lecture 2 months ago in Mayo Clinic, and ophthalmology department people were there, ophthalmology chair, and they called me later and they told me that this may be the way to go with this pseudotumor disease. I think they so. I don't have experience, but I think we should look into that.
Okay, Matt again.
Yeah, I think I want to refer to your paper published recently. One important point you have mentioned, where to cut the falciform ligament. Immediately on the top in the center, or on the medial, or on the lateral. And I found from your measurements, the best, safest area is the medial part, superior medial part of the falciform.
So for the right optic nerve, I go from the right side most of the time, unless, we have to go from the left side. I think going straight above the nerve is not good because there is no space. You have to go on the lateral aspect. So I go on the right lateral when I go from the right side, because as you know, ophthalmic artery gets there with the hook. You can lift it off the ophthalmic artery and you still have bottom controlled when you open it. On the left side, as you go over there, you'll cut it from the medial side, as I showed on the first case, because that's the space also on the medial side. But I would not recommend doing it exactly above, because you would be shoving, this is 1 millimeter or half millimeter hook, but it's still a mechanical element going into optic canal before it's released.
Okay, thank you. I think that we have to pass to the next speaker, our friend Basant Mishra, that is from Mumbai, and he will talk about dilemmas. Misha told us how to solve.
Yeah. I'm trying to see if I can share my screen. Can you see my screen?
No. Not yet.
You're seeing my screen? I can't see it.
No, not yet. We don't see it.
Yet. We see you, but not the screen.
No, I don't know why it's not opening up here. I don't know. There's some problem. It's writing participant. You are sharing your screen, and it's writing your participants can see your screen, but I can't see neither. I think you're not all seeing. I don't know what's the problem.
I think must be something to do with the Mac, Basanji, because I've seen it happening.
Yeah,
before.
but this has never happened to me before. I mean, I always use Mac for so many years. I don't know. Maybe I think if you can go on for the rather than wasting time, going to the next talk, if I screen opens up, because I can't open it.
Okay, I think that this is one dilemma. There is any other question or comments about all the presentation this morning?
No, yeah. That would be me.
Yeah, Vladimir?
Yeah, okay. Let me share.
Are you seeing my screen now?
Yes.
Yes?
Yeah, we are seeing your screen.
Okay, we see you.
See you.
Okay, go ahead.
Are you seeing my presentation?
Yes.
Yes.
Okay, thank you. So it's a thank you, Imad, and thank you, Vladimir, for inviting me for this the prestigious thing to talk in a symposium honoring one of my great heroes of all times, Professor Robert Spetzler. So one of my dilemmas today is, do I talk about Spetzler or do I talk about my journey influenced by Spetzler? It's difficult to talk about Dr. Spetzler because time will be insufficient, because he has influenced generations of neurosurgeons. Suffice to say that I think he is a gentleman who has happened by genetic engineering of Drake's elegant demeanor and Yasser scales. If there is a guy who has that pleasant personality of Professor Drake and the skills of Dr. Yasser, I think that is Robert Spetzler for me. My journey has been influenced by Dr. Spetzler over the period of probably 30, 40 years. And my first interaction, personal interaction, was in 1989. During the World Congress, we did the Satellite Vascular Symposium in Trivandrum, and I was the chair of the scientific committee, young assistant professor, and Professor Spetzler was our honored guest there. And obviously, we were all, I mean, he was already a big, celebrity, neurosurgery celebrity, so that is where I interacted with him. But I think he noticed me first time in 2002 when we were co-faculty in the ASEAN Meet. Because he has really, kind of promoted me significantly and has come to my meeting. In fact, he came to the 2000, we did a WFNS course in Goa. He flew for 24 hours to stay with us for 24 hours and went back. So I'm very grateful for him. For many times he has come on my request. And this was the WFNS course in Goa where he came. And he, of course, I think was responsible for my being in this very prestigious symposium, which my good friend Jack was the scientific chair, and Professor Heros was the Congress president in the WFNS 2009 Congress in Boston. I was part of this prestigious symposium because of him. And of course, we shared many sessions together. And he came as the honorary president in the International Conference of Cerebrovascular Surgery in 2016. Again, flew to Mumbai all the way for this meeting. But let me talk something about the dilemmas of a neurosurgeon in general, not as a vascular, as a skull base, but for a neurosurgeon. So when I was young, for me, everything was black and white. I had no confusion. I have very little confusion. I thought whatever I was doing was right. The more experienced I get after 40 years, the more dilemmas I have. And unfortunately, that's a fact. I will address some of the dilemmas on these aspects: acoustic neuroma, chordoma, with some examples, intramedullary tumors, aneurysms, and cavernous. Now, vestibular sonoma, we all know, there's a big dilemma about what is the best way to manage an acoustic or vestibular sonoma, whether to do anything at all for an intracanalicular or a COOS1 tumor or COOS2 tumor, whether to do microsurgery or radiosurgery. And this is after I have done about more than 2,000 CP angle tumors and about 1,300 odd acoustic neuroma. I still have sometimes a dilemma to advise appropriately a patient when the patient, especially in India, after you explain all the pros and cons, they will come back and ask you, doctor, what do you suggest? So they put you on the dock, and that's a problem. So there are surgical aspect. Of course, this is well described in the literature, the different types of approaches. We have the upsides and downside, pros and cons of various approaches. I think this is very well discussed. I wouldn't go into that. For my take is all the patients of CP angle acoustics are operated through one single approach, that is a retrosig approach, because we believe that all sizes of tumor, whether it's an intracanalicular tumor or a 6 centimeter tumor, can be treated by this approach. Hearing preservation is possible when you are attempting it and the patient has pre-op good hearing. There is a very small bone anchoring at the intra-auditory canal, unlike in a meningioma. So all that you need is to have this bone access. And so once you decompress, even a giant tumor, you can very well take it out by a retrosig approach. So I don't think we need to do an extensive approach for this tumor. Obviously, the major controversy is COOS1 and COOS2 tumors, whether to do anything at all and what to do. So if you go to the literature, there is evidence, unfortunately, surgery, neurosurgery, very little class 1 evidence is there. But these are some of the published data. 2012, you see they had a 381 patients of COOS1 type were observed, and more than 2/3 patients never grew. So only 33% patients showed significant growth, and some of them even grew after 5 years. Now, there was another publication in 2014, almost similar, 31% had further treatment. So basically, more than 70% or 65% tumors of intracanalicular acoustics never needed any treatment over a period of maybe 6-7 years. So we have also changed our paradigm based on this data. But to compound the controversy, this is the publication from the Pittsburgh group by Lunsford. Again, they treat most of their patients with upfront gamma knife, but COOS1 and COOS2, with the idea that they can preserve hearing for a longer period of time. And this is the publication they have published, which you can see that hearing preservation is very good preservation at 5 years when you treat very early. And just this year, Regis presented at the IANS in Belgrade, and they also, the French group, they advocate that it should be early gamma knife for acoustic, intracanalicular acoustic with normal hearing. Even if it is picked up incidentally, they would advise, because they think that the hearing preservation is the best when the patient has a normal hearing before gamma knife. So this is the microsurgery data for intracanalicular tumor, and these results have never been duplicated. This is a Japanese series in 2014. You can see there is hearing preservation was 80% and follow-up of 7 years. There is no publication which I'm aware where there is this similar data is available, and they had normal face in all, and there was no tumor recurrence at 7 years. So this is very, very really dramatic data which has been presented. But this is similar data could well a little more, which has been a little more duplicable, is they have also had a good hearing preservation. But the important thing to remember that is in COOS1 tumors, 25% of the serviceable hearing went to non-serviceable hearing. And there was some facial weakness in 1/4 of the patients. So there is a little bit of problem for me, for a patient who comes in incidental or minimal symptoms or a tinnitus and almost a normal hearing, to advise and go in for microsurgery with this kind of data. So I cannot convince myself that I will go for it. Now, what about COOS3? Now, COOS3, most of the time we can have very good outcome. This is, I will skip some of the video. This is more of a philosophical talk, but we, as I said, we have a large experience, and with a standard approach, retrosig, and we always take out the intra-aortic canal, we drill it, we remove the tumor completely from the intra-aortic canal, and we try to preserve at the end of the surgery of both the cranial nerve 7th and 8th. And we monitor BERA if the patient has good hearing preoperatively, and you of course monitor the NIM monitor for the facial nerve. So this is the patient where this is an Iranian girl who came to us, and this is a small tumor, it's not a big tumor. COOS3, we had a very good preservation of the function. And this you can see the facial nerve being stimulated to see at what level we are stimulating. And so we could preserve very nicely everything. And we nowadays, we fix the bone with the idea that probably reduces the risk of post-operative headache. So this is some fat there, and the patient has very good facial function and normal hearing post-op. But unfortunately, this is not always the rule. And this is yet another lady with similar tumor, complete excision, post-op, good facial function. There's a pre-op normal hearing, post-op there is a drop of hearing. This is more often, this happens in my hands than a normal hearing after the surgery for a COOS3 tumor. There is usually a drop of hearing in many of these patients. As opposed to that, when you do a COOS2 gamma knife, about 12 gray and 50% isodose, there's almost always this normal hearing, at least for 3-4 years before they drop their hearing. And the main advantage, I think, if the patient has a normal hearing pre-op and you do a gamma knife for COOS2 tumor, the hearing, when it drops, it's a gradual hearing drop, which the patient doesn't even notice. Whereas in a microsurgery, if there is a drop, there's a sudden drop immediate post-op, and that patient does notice and gets discomforted with that. So how do they compare the hearing? Hearing, if you compare The radiosurgery, the better preservation, observation almost similar for a few years. Microsurgery, there is a little less, and in our hands, the hearing preservation has been about 62% in the small tumors. There is no significant data to suggest there is a critical malignancy risk, though the radiosurgery, there is 10 times more in 1 in 1,000. So the other minuses, the radiosurgery, the follow-up needs to be continuous at least for 10 years, I mean, even sometimes longer. So that's that the patient has to be available for follow-up. In the microsurgery, there is a risk of facial paresis, which is higher, and the complications, other complications, infection, CSF leak, and so on, even if it is less, it is there. And there is a sudden loss of hearing. If you're losing the hearing, the patient does notice it. However, if the patient loses the hearing slowly, as both in radiosurgery and observation, they sometimes don't even realize that they are deaf on that side. And observation, there is a 31% patient failed and needed further treatment. So our recommendation now in intracanalicular tumor in my practice, always they go for a period of observation. Only when they are very symptomatic, significant vestibular dysfunction, they would need further treatment. Or if there is a growth or there is a hearing drop, then we would go for treatment. Now, if there is an intracanalicular tumor and is symptomatic, we would advise microsurgery because we think we can preserve hearing and which will last longer than other modality of treatment. What about the extracanalicular acoustic tumor, COOS2 and COOS3? Now, this is a presentation in 2007, and we said that if the patient has good hearing in a young patient, we would go for microsurgery, and if he's deaf, we'll go for radiosurgery. We audited our results, and we realized that our results of hearing is worse in the microsurgery than the gamma knife for COOS2 and COOS3. So the patient has a normal hearing today. We would, and he's quite conscious about, I mean, he's quite serious about his hearing preservation. We would today advise gamma knife because the preservation of hearing is better. And if there is a loss, it's a gradual loss. So we have moved on. We have changed our paradigm for the management of vestibular sonoma. So we shift gears a little bit. And I'll talk about some problem of confusion about the ICA aneurysms. Now, this is from Finland. Now, where Harnishniemi was there, and I mean, most of their cases were treated by microsurgery. And this is a publication, I think, in 2021, where you see, 2022, a study of 62 patients with 76 ICA aneurysms, all were treated by flow diversion. So this has completely changed after UHA has moved away from there. And so this has become the standard of care in many Western centers for proximal ICA aneurysm, and the vascular treatment has been the standard of care. And this is another one. This is a publication with the pipeline device, 316 cases in 2018. And they concluded that aneurysm size had no significant association with an aneurysm occlusion status. There was the age older than 65 years, prior stent placement across the target aneurysms, longer follow-up duration associated with incomplete aneurysm occlusion, though size was not a significant factor. So if the patient with a proximal ICA aneurysm comes today, which is especially unruptured, the standard of care, which is accepted all over the world now, is flow diverters. But what we don't see, I think, in the literature is the complications. Now, this is a few I see more complications than what is reported in the literature. This is a patient, the man who was treated for this ICA ophthalmic aneurysm with flow diverter, unruptured one. What happened 3 months down the line? He came to us with progressive visual compromise, significant edema. And we put on steroids, didn't improve, and then he disappeared from follow-up. Now, this is yet another patient, again, similarly treated with flow diverter, unruptured giant proximal ICA aneurysm, multiple complications, landed off finally with hemiplegia, aneurysm was still filling. Unfortunately, many of these things are never been reported in the literature. Now, this is a patient which I saw subsequently, is a 62-year-old gentleman who had sudden onset of headache and vomiting September 2019. He had diminished vision in the right eye, restricted right eye movements, and decreased sensation on the right side of the face. Fifth nerve involvement from this giant cavernous carotid aneurysm is significant thrombosed component you will see in the MRI. And he was treated by an outside center with a flow diverter in October 2019. What happened to the patient? Now, post-procedure, patient lost his vision, which was on the right eye, which was less. He became blind on the right eye within period of 1 month, and the headache persisted on and off. And then he followed up with the endovascular colleagues. The aneurysm mass kept growing and growing and growing. And then patient underwent, you can see there was a leak there. So patient underwent a second flow diverter in February 2020. After the second flow diverter, what happened? The patient finally presented to us in March 2022 with blindness. He became completely blind after the second flow diverter for 2 years now. But now March 2022, he presented to us, the blindness was there, plus headache, vomiting, and started having epistaxis. And then the endovascular colleague, another endovascular colleague, which he went to, referred to us because the patient, he said the patient may die of epistaxis, massive bleeding. So we almost a semi-emergency, we did a right ECM to radial artery bypass graft and ligated the carotid in the neck. I'll skip the video. And you see the post-op CT angio, so the patient patent radial artery graft. Fortunately, the epistaxis stopped. Of course, blindness persisted, and his headache, he's still there. We hopefully, over a period of time, the aneurysm will decrease in the size, but as of now, the mass is still there. So in the proximal ICA aneurysm, the FT flow diverter devices has definitely revolutionized the management of aneurysm, but its risk cannot be ignored. Endovascular therapy is known to transform a giant aneurysm into a chronic disease. While flow diverter is good for small and proximal ICA aneurysm and a large proximal aneurysm, unruptured one, is not the best treatment for giant aneurysms, especially with significant mass effect and a visual deficit. And this has just been published in Journal Neurosurgery, is going to come out soon. The case report. So when we see a unruptured giant cavernous carotid aneurysm or a carotid ophthalmic aneurysm, we treat it today with visual compromise. We would treat by microsurgery, and this one was direct treatment. It was a giant ophthalmic aneurysm, 4 centimeter with a visual compromise, fully circulating, unruptured. We did a microsurgery, like a kind of aneurysmography, and because this will take time, so we did a STMC bypass to tide over the time of temporary clamping, so that patient does not suffer from ischemia during the temporary clamping. So next confusion in my mind is the brainstem cavernoma. Now, this is the natural history. The brainstem cavernomas don't do well as other cavernoma. The risk of bleeding is high. The hemorrhage, fatal hemorrhage is high than other location cavernomas. So brainstem cavernomas probably need treatment. And we do that. We believe that this is the best way to go forward. In the literature, the total excision rates are about 91%. And the residual, but the rebleed rates are very high. And this is one of the Dr. Spexler's favorite subject. He's taught us how to treat cavernomas in various sites. We have followed that. Now, so what is the data in the literature? Now, this is, again, from Pittsburgh. You see the radiation surgery associated with greater than 30-fold reduction in the baseline risk of symptomatic bleed in cavernomas. Now, contrast that to this data from Karolinska by our friend Mathisen, exactly the opposite. The 40% rebleed rate increased 40% rebleed rate. So which one do you believe, and what do you advise to the patient? This is evidence. This is in the literature. This guy says that 30-fold decrease, and this gentleman says 44% increase. So that's the problem, because unfortunately, because it's not pure science. So you need to have, I would suggest for the young neurosurgeon to have his last 100 cases and decide what to do the best in his hands. So the expert opinion, what is that? And this is Batlanfi, who has a large series. Again, they recommend that radiosurgery is not the way to go. This should be operated. Steiner, the guy who started radiosurgery for vascular lesions, they published that the complication rate in radiosurgery prevention carcinomas are very high, and that's not the way to go. They suggest that should be microsurgery. Now, the main controversy is not for aggressive, accessible cavernomas. Everybody agrees, even the Pittsburgh group agrees that this should be operated. There is no controversy about that. And mostly people would agree also, most authors, including us, we agree that if it is silent cavernoma, docile cavernoma, which is not reaching the surface, it is better to left alone. The controversy is about aggressive, inaccessible cavernomas. And the Pittsburgh group would say that this should be radiosurgery, and most other authors would say that this should be left alone. And we would say that it should be left alone. So symptomatic, accessible brainstem cavernoma, also microsurgery, even the Pittsburgh group, they also say that. No radiosurgery. So the problem with radiosurgery, how do you evaluate? Imaging evaluation is not possible. Comparing with pre-radiosurgery, pre-treatment history is fallacious, and there are some associated complications. So in our hands, what we advise, if it is asymptomatic, incidental, we would advise observation. If it is symptomatic and aggressive and accessible, we would go for microsurgery. If it is inaccessible, we would go for observation. If it is docile, we would go for observation. Now, the next part of my talk is chordoma, and I'm timing it. Let me see how much time I have left. I think I'm running out of time, so I will skip, I think, the chordoma part. I think will take some more time. I'll skip that. But I'll just say that when we do a skull base through endoscopic endonasal surgery, there's sometimes a problem. And it needs, of course, a training curve, but there is an inherent problem with endoscopic surgery because they are blind areas. And this is an exaggerated cartoon, but I think this will give you the meshes. So there are blind areas which, if you're behind the tip of the endoscope, so unless you are careful, that can be a problem. So that is my last slide of this one. This is an intramedullary tumor of a 30-year-old male who presented to me 10 years back with right upper limb paresthesia. That's about it. And that's an intramedullary astrocytoma. We had many more images. We just kept on observing because the patient was absolutely intact except the right upper limb paresthesia, which was responding to pregabalin. He didn't have any other symptoms, and he said that I would like to wait. And this is after 10 years, after 12 years, he came back. First time I saw 2010, and this is after 12 years. There is no change, no deficit. He continues to have this little bit of paresthesia, which doesn't disable him, and he is fully functional. And so this is where do we stand? I mean, intramedullary astrocytoma, we would like to treat or not to treat. We didn't, and this is how it is. And finally, the COVID told us, and I realized that sunset in Mumbai is so beautiful, which I never saw because in India, we all work very, very late. I never came home before night. So I didn't see that till we got, quarantined in the house. So how much is too much? After that, I've been thinking about it. What do I advise my residents? Before COVID, I would always say that work for 16 hours today, then when you are 50s, 60s, you can work for 12 hours. But is that the right advice? I don't know. Thank you very much for your attention.
Thank you, Amazan. Beautiful presentation, very provocative. Any question? Any comments about? No one?
Just a comment. Basant, I thought your presentation was beautiful, Basant, especially for the cavernoma portion of it. You cannot dissect it out more beautifully. The problem is the evidence in the literature is sometimes not coherent, and you also have to do what works best in your hands. a diligent observational approach, and then what technically is available to you in the institution may be the right answer to the patient. And since this gremium has a lot of gifted surgeons on there, microsurgery is a preferred option for many of us. So I appreciate your educational talk on this part of the lecture. That was beautiful.
Thank you. Thank you very much.
Any other comments? If not, we close this first section, and I ask to Vladimir no, I'm sorry, to Imad to take the chairmanship and to introduce the next speakers.
Thank you, Giovanni. It was a wonderful first sessions, and I'm glad now we have Professor Robert Spetzler with us on the podium. I can see him. Before I start this session, I'd like to say a few words for this occasion. It's a great opportunity, Rob, that you join us and accept the invitation. It is, well, I was talking to Vladimir, this is the gift for the International Academy. We were the Christmas guys giving the gift before the end of the season of the IANA for this year. We established this academy just recently, a year ago, focusing on training young neurosurgeon and education. And it reminded me, last week I was chairing a session on a title by a neurosurgeon from India, Agony and Ecstasy. And I just want to superimpose this one on Professor Bob Spetzler, that he left his country, Germany, when he was, I think, 11 years old, and then he moved to Chicago to study there, and got from Northwestern his MD, and then got his special training in neurosurgery in University of California, San Francisco, under the legendary Professor Charles Wilson, God bless his soul. And of course, the projection of the agony of and the ecstasy of Professor Spetzler, it reminds me about the book who carried this title in 1961 by Irving Stone, where he reflects on Michelangelo as an artist. And we summarize on the brochure the three words for her to describe Professor Spetzler: the artist, the innovator, and the great educators. There are many have invited. I'm sure many, they are not happy with me because I could not invite the whole world, but I have representatives from your previous pupils, and I met many of your pupils. They were a close friend of mine. I met Neil Martin, Mark Henry, Jack Marcos, Abramsky, and Ian Kalfas. Recently I was talking to him, and of course, many other. And you see, you left that nice project, and you didn't take the simple case to give us a presentation. You always take the difficult cases, which is usually the behavior of neurosurgeon. They don't want to show a small meningioma and the complexity and say, look, I took it completely without a complication. You took the giant aneurysm, you took the Petroclival meningioma, you take the eventually brainstem and cavernoma, all these tough aspects of the practice of neurosurgery, and you made it simpler. You made it look simple. When you are in, we have the difficulty, but you made everything look simpler by the way you have taught us how to approach, and with the talent and the artistic manually and judgment. So without further ado, on behalf of the IANA, I'd like to welcome you, and we will start with one presentation on cavernoma by Professor Vladimir Benish, who has been instrumental in running this activities with the World Federation to start with, and then we joint venture on this new academy. And I leave the venue for Vladimir. He might like to say a few words, because we all here were at different stage visitors or trainees of your expertise. Vladimir?
Yeah. Okay. Let me share the screen. Do you see my screen?
Yes.
Very good. All right, I'm going to talk on cavernomas, and Dr. Spetzler will then talk on cavernomas as well. It is rather difficult. It's like driving Volkswagen Beetle in front of Ferrari. So I'm probably...
You make the Volkswagen full screen, yeah, Vladimir.
I did. That's my usual problem, that I have my good...
All right.
On my screen, it's all right.
Okay.
And you do not have the presentation mode. Am I right?
You are not in the presentation.
No, you're not in the presentation mode, Vlad.
No.
Yeah, I do not know how to do that, because on my screen I have the presentation mode.
Oh, I see.
All right, let's do it this way, because I really do not know where the problem is, and it's repeating all the time. I have nothing to declare, which is quite obvious. And I just would like to say that I consider Dr. Spetzler to be one of my 4 teachers. The most important, of course, was my father, who passed away a year ago in the age of more than 100. But I have spent a year with Dr. Spetzler in Phoenix in 88, 89. And Dr. Spetzler probably was the one who showed me neurosurgery in all its complexity, and who also has shown me that it's not only neurosurgery, but also some fun, some sports. If you are playing volleyball along with Dr. Sontag, I do not know who these other 2 guys are, but as far as I remember, this was the Olympics which we have had.
The slide is not advancing, Vladimir. The slide is still the first one.
Still the first one.
Yeah, change it to the one you're talking
about. I'll try to do the new share.
No, you're sharing, but the slide is not advancing.
I do not know what to do, Ramesh. You are sharing screen, which I do. On my screen here, it's okay. Not on your screen.
No, you may have to maybe come out and maybe reshare it, because we're not seeing the next slides.
All right, I should stop share. I should try again. And now the presentation mode. Is it all right now?
We can see the first slide, but are you able to advance it by clicking the arrow button or something?
Yeah, Vladimir, I think you're on the wrong screen. You have to move over to where you see that other form and then hit presentation mode.
All right, so I shall.
So move your screen over to where you have that.
I've got share screen, which I now
you are.
do. Yeah,
you
now
are
I
sharing
click
it
on the presentation.
right.
All right, now
are you using 2 screens?
No, one only.
Yeah, click on that one. Click on that one. Let's see what happens.
Now you have the first slide on your screen.
Yeah, click on the cursor now where you are touching the screen mode.
Right.
Yeah.
Click that.
Click on it. No,
you see the first slide?
Yeah, we can see the first slide, but it's not in
All right, so I should try to advance. What about now?
Advance.
Yeah, okay. So I have nothing to declare, which is obvious, because in cavernomas it's difficult to declare something. It is a slide when we were playing with Dr. Spetzler and Dr. Sontag volleyball.
No, we don't see it, Vladimir. Are you
No.
I really do not know what to do.
If you click on the slide on the side, see whether we can see it. On the 3rd slide on this sidebar, can you?
No, I don't have it here.
Oh, okay.
I stopped sharing. Now I share the screen again, like that. Now share. Do you have the first slide?
It always comes to the first slide, but it's not
on the presentation mode.
Do you have the second
slide? Now we can see the second one.
No, I shall do it this way, because it's probably
we see the second slide now. Go on with the same thing, go to the next one. Yeah.
I should go like that. So I have nothing to declare. And here we are playing volleyball with Dr. Spätzle and Dr. Sonntag in some Olympics against UCLA, and it's 1988-89. I've spent a year at BNI at the time, and to be quite honest, I'm still living out of it. You know, what I have learned there, I'm still using, and I really, it was the best year in my life actually there. And I'm very grateful to you, Dr. Spencer, that you let me be there with you. That was really, really great. All right, general remarks. Cavernoma treatment is about the decision whether to treat the cavernoma or not. Cavernoma surgery is about the approach. And there usually are more avenues, more approaches which we can use to single given, especially deep and brainstem cavernoma. Of course, the risk of surgery must be lower than that of the natural course. What I'm going to do, I shall show you a few cases to get into the mood of cavernomas. Then I shall put some questions which are in my mind at least unanswered, and probably some of you will be able to answer that, especially Dr. Spätzle, because at the time when I was there in 88, 89, cavernomas were new, and it was probably the most frequent lesion at BNI in that year when I was there. And then I will show you the meta-analysis which we did, which raise probably more questions than answers. This is a mesencephalic cavernoma. We can approach this cavernoma either supra-infracerebral or occipital subtemporal. We probably could go transchoroidal through the third ventricle, whatever. What we decided for was this suboccipital route. We easily reached the cavernoma. This is after the surgery. Another one in the fourth ventricle, we could go teloveral, but I saw that this is probably a little too high up. So what I decided for was supra-infra, which the videos probably will not play. With cutting the cerebellum paravermian short 2 centimeters cut and resecting the cavernoma that way. You see the very short cut which was there. So again, at least 2 approaches. The same thing is this one. It's upper pontine cavernoma. You can go either supra-infra or retrosic or transpetrosal, whatever you name it. We decided for supra-infra. On the right, you see the late control, and this is the next, the other cavernoma which grew up later on and which we are still observing and not doing anything about that. Thalamic cavernoma, posterior thalamic cavernoma, again, several approaches possible. We decided to go again through supra-infra route, cutting the tentorium very modestly, resecting the cavernoma, and that after. This is the 18-year-old boy who had experienced sudden hearing decrease. And in this case, there is no doubt that the only way probably is retrosic. This is during the surgery. You see the cavernoma, you see the after the cavernoma, and quite surprisingly to me, the boy regained normal hearing within few days after the surgery. The next cavernoma is upper cervical or oblongata. First, I tried to go through far lateral approach. You see the cavernoma. I saw the cavernoma, but whenever I touched the cavernoma, MEPs went down. So I just simply ran away. I was scared of doing anything by this approach. And later on, we went through the midlines, through the spinal cord, resecting the cavernoma without any deficit. You see the final images. So which problems do I have, or which questions I still have? Disease dynamics. It's something which definitely depends on genetics, and which we probably will be able to learn more about. This is the cavernoma within the basal ganglia in 2006 and in 2015 without any deficit, without any bleeding. The cavernoma is perfectly stable and still the same. Another cavernoma does the opposite. It was a pituitary patient, and you see that in 11 he was doing well, as well as 13. In 14 there was something already appearing. In 15 there was full-grown cavernoma which we resected. This is this image, but again he came with relapsing disease and with bleeding, and the patient ultimately died of another and another bleedings. Whatever we did, we were unable to stop the disease. Then multiplicity. They are either multiple, that you get the patient with multiple cavernomas, which is quite frequent. And then there is something I call successive multiplicity, when the new cavernomas are growing. Again, this would depend on genetics. So this is a cavernoma which bled over here. And there are a few other small ones. And in these cases, we of course go the same way as in hemangioblastomas in VHL, that we resect only the one which is symptomatic. Here the guy had epileptic seizure, so we resected only the cavernoma, and all the others we just follow. So one of the largest which I ever had in 1999. She was 15 years old at the time. We resected this cavernoma. This is after. There was in 2 years another cavernoma, parasagittal. We resected that one as well because we expected that it would grow the same way as the one, as the largest one. And she came back in 2017, 2 kids later. She was a young lady with these 2 cavernomas. And we expected that these 2 cavernomas would grow, so we resected them as well. So this is something I call successive multiplicity. This is the final image. Then epilepsy. Should we go like for epilepsy surgery or cavernoma surgery? The patients are coming to us via 2 ways. One of them, part of them are coming via epilepsy centers. Then we go on by epilepsy resecting a little more, which I hate. I think that cavernoma resection should be enough as the first step, and only should the epilepsy be intractable, then let's go for epilepsy surgery. And the other part of the patients are coming as cavernomas with epileptic seizures, not undergoing all those workups for epilepsy. These we treat like cavernoma. This is a large cavernoma on the left, who came like epilepsy surgery, all the workup, but still I resected only the part of the cavernoma at the medial parts. I was stopped by electrophysiologist, so part of the cavernoma remained there. There is one other occipital which we left behind, but the task was completed because the patient was epileptic seizures free after the surgery, only by partial resection. So probably some of these patients should really be treated like epilepsy. And then timing, in my mind, deep and brainstem cavernomas are not urgent unless clinical symptoms call for that. I like to have the hemorrhage cavity walls firm enough, and they should be firm enough in 10-12 days. But usually we do surgeries like 2 weeks, 3 weeks after the bleeding. It shouldn't be that too long, because then the hematomas will get too firm and even calcified, and then the resection is rather difficult. So this is the meta-analysis which we did, and which is the core of my presentation. We looked for surgery, radiosurgery, and natural course. We followed all the rules for meta-analysis, and meta-analysis is definitely the highest level of evidence. We collected 9,000 patients and 41,000 person years, so that already should be significant. We have had more than 100 articles. The work was published in Journal of Neurology, Neurosurgery, and Psychiatry, and just graphical results very simply. This is the risk of cavernoma bleeding in 40 years perspective. On x-axis are years, so we are considering 40 years. And on the y-axis is the risk of bleeding, not the risk of neurological deficit. That was or death. That was something we were unable to find out of that. So this is just the risk of bleeding, not the risk of bad result. And you see bluish is natural course, and definitely radiosurgery has a beneficial role, which was for us a rather surprising result, because all our community for many years were saying that cavernomas are not subject to radiosurgery. I believe that they may be subject to radiosurgery because definitely the risk of bleeding is cut at least by half, and the patient has benefit in some 10-15 years when he's crossing the natural course line. Of course, the most effective is the red line, which is the surgery. That is the best prevention of bleeding. These are the brainstem cavernomas, again in 40 years, and you see that definitely, again, the radiosurgery has effect, and the effect is very prominent. It's really cutting down the risk of bleeding to some 30% in 40 years, which is, in my mind, very reasonable result. But of course, surgery is better, and that the effect for the patient is in some already 10 years in the prevention of bleeding. And now I'm going to cut the branch on which we are sitting. You see in the same scale the brainstem and deep structures cavernoma on the left, and on the right there are hemispheric cavernomas. And in hemispheric cavernomas, we again are talking about the risk of bleeding only, not about the risk of serious morbidity or mortality. And you see that in 40 years, we hardly bring any benefit to the patient. We decrease the risk of bleeding very modestly, and actually this probably should mean that all those hemispheric cavernomas, apart from epilepsy patients, probably are not subject to any treatment, that the observation should be enough, and only should the cavernoma grow, then probably we should consider the some treatment option, either radiosurgery or surgery. So what I would like to conclude with on this meta-analysis is first thing that there is definitely beneficial effect of radiosurgery, and that we probably should be only observing the cavernomas in the lobar areas. So this is what I have said, that radiosurgery has a beneficial effect given the low risk of bleeding and even lower risk of serious morbidity, mortality after the bleeding in lobar cavernomas, should we treat them at all. Brainstem and deep structures, definitely surgery provides the best treatment option. Should not be those within eloquent areas, say the cavernoma within the motor tract or directly within the speech areas. They probably would be dangerous because these cavernomas would most likely cause some deficit when bleeding. So I would enlarge these brainstem where the structures are packed and functions up along the tract and center of high eloquency. We also have propranolol, which should be studied and which may be beneficial and which may be just enough for the patients with some cavernomas. And of course, as always, it's an individual decision what to do. We have put this not in this book, but all the technical remarks, genetics and everything is treated by respective chapters in this book. These are the two wunderkind who did all the work with me. They have combined the IQ of 400, Professor Bradač and Ms. Bubejníková, excellent people, very, very industrious, and they did this meta-analysis of 9,000 patients, 40,000, 41,000 patient years. And this is just to finish that even after the many years, I'm still learning from Dr. Spetra. So I have learned from him in 88, 89, and here we are. I do not know where it is. It's probably Istanbul, once meeting, and even after that many years, there always is something which I can learn, and always listen what Dr. Spetra is saying, because it always is of value. Thank you very much.
Thank you, Vladimir. Any comment or questions? Bob, Dr. Ramesh.
Thanks, Vladimir. That was brilliant. It's you gave us an overview and touched upon this difficult area where to how to make a decision, and Prof. Mishra also went through it. One thing I just want to mention, when there is a there's a dilemma in whether to treat or not to treat, and also when you treat, whether you can treat with the gamma knife or with surgery. And in UK, we have just started a pilot trial, which is called a CARE trial, which is a randomized trial for...
I know about it.
Yeah, so we will probably, hopefully, will complete the pilot trial, and then we will have some idea about, in some situation, whether to treat or not to treat, or whether, as you've shown in your series, I think the meta-analysis about the gamma knife, there is some benefit from it, and also that will be looked into in one of the arms of the trial.
I know the trial is running in Britain, but the quality of evidence or the value of evidence, even the randomized trials are below meta-analysis. So I'm pretty sure that you will find out something which I have just presented.
Think so,
and it really raises the question about the lobar cavernomas, whether we shouldn't be just observing, because we were unable to find the risk of, not the risk of bleeding. Risk of bleeding is obvious, but risk of bad result, risk of serious morbidity and mortality. That was impossible to draw this data. We are still looking at it, but it's almost impossible. So probably your trial in Britain should find this.
I'm sure there'll be subsection.
I hope so.
Yeah. Thanks.
Well, I'm just remember Professor Steiner, he used to say for cavernoma, they ask low flow malformation. They don't respond at all with radiosurgery. Things perhaps has changed after 20 years. The people, they used to treat the AVMs only with radiation therapy. Now that trying to go to the cavernoma to think about the potential option of treating with radiosurgery. What is your Professor?
That was the argument. There was always the argument that cavernomas are low flow and single cell layer lesions, that these cannot respond to radiosurgery the same way as the AVMs do. But it's probably wrong, and probably radiosurgery, be it gamma knife or cyber knife or whatever, really may be beneficial. And there still is propranolol, which should be studied probably more closely.
Yeah, I think, Vladimir, that was really a great presentation. The trouble with meta-analysis is it all really depends on the quality of the data that has been collected worldwide and put. Just because it's a meta-analysis doesn't make it any better than a single analysis of high quality. And the trouble with radiosurgery, as an example, like Steiner referred quite a few patients to me because he didn't believe it was effective. Lunsford, who thought it was really effective, there was a trial initiated for brainstem cavernous malformation, a prospective trial, and it had quite a few participants. And the point was, when you found a brainstem cavernous malformation that was not appropriate for surgery, then it would be randomized. As it turned out, not a single patient was admitted into this sponsored study. So we have to be very careful. Nevertheless, what you present is what we have out there, and it's valuable. I mean, it's a guide. I personally remain unconvinced that radiosurgery is beneficial, but the whole purpose is to have data, and let's see what the English study demonstrates.
Yeah,
I'm looking
I
forward
definitely
to it.
was under your influence on the side of active treatment, on the side of surgery,
Yeah.
and definitely was saying that radiosurgery is just for
Right.
nothing. You know, that was your influence, actually.
Yeah, I know. I have my own
No.
bias.
Now, yeah, me too. And now that we do this, I'm really somewhat hesitant.
Yeah.
You know, of course, there are downsides of meta-analysis. Of course, of course.
Right.
That's
Yeah,
only
but
the summary of
very
numbers.
very quick comment, Vladimir. The major problem, I don't know. I mean, I do gamma knife, but we don't gamma knife for cavernomas ever. The major problem to my mind is how do you follow, and what is the I mean, how do you decide that this is effective? Unless until you have a very good follow for many years, how do you decide? Because AVM disappears, but cavernoma stays there, and small bleeds. Yeah, small bleeds. That doesn't make any difference unless there is a large bleed. You know, so that's a major problem.
They stay there, but they do not bleed.
Well, small
You
bleeds
decrease the
you
risk
not
of
know.
bleeding. You know, by radiosurgery. I don't like you all are saying gamma knife. We are having cyber knife, so I would like to talk on radiosurgery, but doesn't matter. It doesn't matter. But you know, we are following quite a lot of patients with cavernomas, with hemispheric cavernomas. It's a bit an older patient, whatever you name it. You know, there was a time where we operated almost all the cavernoma that came to us. Not anymore. Now we are much more hesitant, and we switched, being probably more active in brainstem. Even in those which are or which seem inaccessible, we still find a way and do surgery for them, because there the bleeding is really disastrous. So we are very active in brainstem cavernomas and less so in hemispheric ones, which are fun to operate, of course. We all like that.
Ek, you have a question?
Now, I just wanted to comment on radiosurgery, which is an interesting aspect here, because the real problem in radiosurgery is the location of the lesion and then the fractionation scheme. If you think about a midline lesion having an 8% per year bleeding risk, the advantage of surgery in the brainstem is that you have immediate control over no further hemorrhage after the lesion has been removed in most cases. With radiosurgery, the problem is you need to fractionate your dose on the brainstem because you have dose-limiting critical structures next to it, which decreases your efficacy. So once you have a decrease in efficacy and poor conformality, then you get less impact on incidence of bleeding post-radiation, and that's very difficult to follow in the brainstem. So I think we need much more diligently designed trials to look just at one category of disease, like brainstem cavernomas, in areas that are difficult to operate on, and then decide in younger patients who will see a long-term benefit, what is your chance of not local control, but local bleeding risk versus what's the immediate risk of morbidity from surgery? Because in radiosurgery, you have a radiation necrosis risk of at least 5% for focal lesions. And how does that match up with an 8% risk of bleeding versus removing the lesion that has no further risk for rebleeding, but surgical morbidity? And what I liked so much in Vladimir's presentation was a relatively simple surgical approach, supra, infra, paramedian, lateral, gives you fairly good access to complex lesions. And in a symptomatic patient, you can immediately decompress the lesion, which gives the patient best symptomatic relief. The problem is, what are we doing with asymptomatic patients? That's my biggest question for the panel.
You are perfectly right, Ek. I would admit that we operate on some asymptomatic brainstem cavernomas as well. If they are accessible, never bled, we still resect them, because once bleeding, they are too dangerous. And I would enlarge this. We are talking always brainstem cavernomas, which is only up to mesencephalon. But the same behavior is in thalamus, is in the internal capsule. So we are talking now about brainstem and deep structures, where the functions are really densely packed and where the bleeding is really causing deficit. And you are right that immediate protection against the bleeding is surgery, of course. And there are necrosis, of course. What I have presented, it's only numbers, pure numbers drawn from the literature. But they say something at least.
Sure, thank you.
Okay, now we want to learn from Professor Spetzler the lesson learned from cavernoma surgery in the brainstem, what it has taught us.
Good morning. Can you see me? Yeah. This has been a perfectly fascinating dialogue, and I will present my own biases. Imad, I thank you for your very kind comments, and Vladimir, it has been a long time, and you certainly were there at the beginning of our journey into cavernous malformations. Do you see my screen?
Yes.
Yes.
Okay. For me, these lesions have been absolutely fascinating because they really have given us a window into every anatomical niche in the CNS and spinal cord. And so my experience, fortunately, has been remarkably rich because of my timing and where I was and the referral patterns. So my goals here is just very briefly to review what we know, give some cases, and then some conclusions. And I think one of the problems for radiosurgery, for example, is this issue. When we have a cavernous malformation that looks like this in somebody that has bled, been symptomatic, and if you would have radiated this here and you would have had this as a result, you would have said, that's a really terrific result. But in fact, here, nothing has happened except for the blood to have been absorbed. When not to operate, which Vladimir really addressed very nicely, is right, when the risk exceeds benefit. Well, if we knew that for certain for every patient, it'd be very simple, but we generalize. But if you have a patient that is asymptomatic or minimally symptomatic with this cavernous malformation, you are going to have an unhappy patient and family if you take this one out. When we talk about selection, this is actually one of my favorite studies. And so what we did is we basically took every brainstem cavernous malformation that came to us during this time period, and we sit around and we discuss whether somebody is appropriate for surgery or not. And so during this 2 period, every patient was seen at this, and virtually half we recommended surgery. These were all referred for surgery, and half we didn't because we thought that the risk of surgery was greater. And I think that's really an important point. Vladimir nicely addressed it. And it can't be overemphasized that selection remains the key. What are the indications? Well, accessible, repeated hemorrhage, progressive deficit, mass effect, and the fact that you have to have a safe entry zone. These are associated with veins, whether you call them venous anomalies or whatever you want to call them. Veins are an important part of this disease, and they are, in my mind, a venous anomaly. Prevalence, symptomatic, this has all been discussed, but we must not forget that surgery of brainstem cavernous malformation has associated with a significant risk, emphasizing the need for really selecting the appropriate patient. These are fascinating lesions. So this is a 7-year-old. You could see this lesion, and you could see the large vein, and I don't think anybody would have considered any other diagnosis than cavernous malformation. Well, this patient was radiated at another institution. And this is what it looked like 16 months later. Totally different. And now I think, untreatable since it had already been radiated, deep basal AVM. I'm not presenting this as a failure of Gamma Knife, but I'm presenting it as there are so many nuances, so many variations in this disease, we still don't understand it completely. And I'm going to show you this particular case, which is just a cavernous malformation here. Patient had a sudden onset of left and arm hand weakness. You see the abnormal vein that's part of the cavernous malformation. And here you see the vein. And here you see the cavernous malformation. Just absolutely an intimate relationship of the vein to the cavernous malformation. Here it's taken out. I don't want to belabor that point. My whole point of this particular case is that this is, in my mind, budding of these veins. There's a budding process that goes to the cavernous malformation. Approaches. Well, I mean, that's what these lesions have taught us, because they really occur anywhere and everywhere. And with the addition of image guidance and with monitoring, we have really been able to get pretty acceptable results in every portion of the CNS. Anatomy, anatomy, anatomy. That's really what your organization is all about. And it's important to remember that even though the brainstem is a very small structure, the different approaches to the brainstem have to be considered for each lesion. We published a paper back in 2015 with my fellow Leonardo, just looking at the thalamus. And we came up with 6 different regions that required each a separate approach. So you could just see that for this region to get there safely, all based on the anatomy, is really the key. These things have made these lesions possible. Adding on light to the end of the instrument really allows you to see in the very, very narrow channels, and really is a nice addition. The ability of robotics. Here you have a pre and post resection MRI scan of a medial occipital lobe lesion. And so that all we're doing is we've identified the target and entry point. And now the microscope is just going right down that channel all on its own. And we go from a contralateral approach, interhemispheric, no retractor in place, and take out the cavernous malformation. Really very straightforward. I'm using one of our suctions that has a light on it just for a little better illumination. And it really comes out very nicely. But I want you to see as we're coming, this is the head is horizontal because your eyes are horizontal and your hands are horizontal, and you're using gravity to pull out down the ipsilateral hemisphere as you're going to the contralateral lesion. So the question is, when you see a lesion like this here, what are your considerations and what approach do you think is important? So you're looking at this and you have cerebellum here, you have temporal lobe here, you have all these different approaches that are available. And the supracerebellar infratentorial, in my mind, is by far the most suitable for this. No retractor required. Positioning, you're going down along the tentorium. And we and others have published extensively on these approaches. And then you get right down to the ambient cistern. There's no spinal drainage, and you come right to the cavernous malformation. You're only using what I call dynamic retraction. That is the bipolar, and your instruments are being used to take out the cavernous malformation. A little different orientation, but with tiny little forceps that have little tooth on it, you can remove the lesion. What have we learned from all these? You need to spend a lot of time at the end of the procedure inspecting the bed to make sure we've gotten every little portion of cavernous malformation we can identify. All the little white tissues that are in there may be residual collapsed endothelial cells. So we want to be sure we get them out completely to prevent, as much as at all humanly possible, a recurrence down the line. And it comes right out. So again, decision-making, that is really the key. This is a medical student. She had one apoplectic event. She has this cavernous malformation. You see the relationship to the fornix. So the first question we really have is observe or surgery. If surgery, what approach? Interhemispheric or lamina terminalis. If interhemispheric, straight up or lateral. And as I already pointed out, I personally like lateral. It's very comfortable for me. It's comfortable for the patient, and you can utilize gravity to get you there. So here we're using image guidance, and we get right down to the cavernous malformation, no retractor in place. And this is really removed very readily with this approach. It's a nice example of that you have to keep looking. When you think the lesion is out, it's easy to find additional little components of cavernous malformation that are hidden in the crevices. So you look and you look and you look. And there's the post-op, there's the incision, there was just a little straight incision, and you see the cavernous malformation gone, and she had absolutely no change in her examination and no loss of memory. One more example of analysis. We have a cavernous malformation that's sitting laterally in the frontal horn, and you really have several approaches that are reasonable. Transcortical, transfrontal, pretty safe approach. Interhemis, transcallosal, ipsilateral. That's a toughie because you're coming down and then you have to get all the way over there. Or you can go contralateral, interhemispheric, and go through the cingulate gyrus. Go through the falx and the cingulate gyrus. And that's the approach that we selected for this. So again, the patient is lateral. We're on the contralateral side. Now we're going with image guidance. We decided where to open the falx, make a small window in the falx, and then with image guidance, go right down a small channel into the ventricle to the cavernous malformation. Again, no rigid retraction is included, and there's our little cavernous malformation. This one is dangerous because it had bled into the ventricle. And here you can see one of the little veins that's clearly part of the anatomy and why they fill so slowly on angiography in the old days, or with indocyanine in green, they fill very slowly. And we take it out. So it's a very small opening, singular gyrus, requiring no retraction. And there it is. You can see the pathway that we came down. So when we look at the spinal cord, we really have sort of the same concerns. It's all about anatomy, anatomy, anatomy. We have the midline myelotomy, which we all use and is very safe. We have the substantia gelatinosum, or the dorsal nerve root entry zone, right next to the nerve root. And then the lateral one between the nerve roots, right at the dentate ligaments. And I'll just very briefly show you one example of each. And obviously, we're making use of the natural anatomical pathways that are as safe as possible for these lesions. So here's a giant one. This was referred to me from San Francisco many, many, many years ago. And it's remarkable. He had very little function left, but inside this little sliver of spinal cord, there was still some function, but he remained significantly affected. Vladimir also mentioned the familial because of our Mexican Spanish population. We actually have a lot of families since it's more common in there. And this is the son that had a bleed, and he was in another hospital. He had an extra lesional bleed, which was very devastating. Great attitude, great, great kid. But his dad had a lesion in exactly the same spot, which is right here. And after 8 weeks, dad came and said, I want mine out. And here it is. And again, nicely demonstrating the relationship of the venous pathology to this cavernous malformation. Obviously, very straightforward to take out. A little more challenging is the one that's off the midline. And so here are the dorsal nerve roots. We're going to go right next to the dorsal nerve root. And very important to make your incision long enough so that you are not hurting the edge when you're spreading the fibers. And you come right down to the cavernous malformation. You can see it nicely. And then we remove it. I love these tiny little forceps that are very sharp that allow you to pick up the tissue and remove it. And old days, I used to say never bipolar in the brainstem or spinal cord, and that's wrong. It's perfectly reasonable. And then finally, more challenging is this one. This is a gentleman from Hong Kong, AAA personality, went all over the place, finally decided to have this out after his third hemorrhage. And here, now we're going to use the approach between the nerve root. Here's dorsal nerve root, dentate ligament right here. So we're going between the nerve roots at an angle to get the cavernous malformation out. And you can see from the different consistencies of the cavernous malformation, the different ages of bleeding. And came out very nicely, and he did very well. When we go to far lateral, I used to make big incisions. I now make very small, just paramedian incision with a small opening. By going paramedian, you avoid the big muscle mass that has to be retracted. This young woman is from England. She is now the editor at London Times, medical editor. And obviously for the far lateral approach, what we want to do is we want to remove just enough condyle to get exposure that we need. So it all depends really where the lesion is as to how much we have to remove. And I won't bore you with this, watching it all the way. So here it is, dentate ligament cut. Here's the cavernous malformation in front of the medulla and spinal cord. Again, you could see the venous component, and we're separating it out. You can also see the different colors, the fluorescent orange and so on, from different ages of her hemorrhages. This young woman wrote a beautiful book that's available on Amazon and called Into Oblivion. Midline, T-leveler. We're all very comfortable with the suboccipital approach, and just remember not to operate if there's not if the patient is not symptomatic or just minimally symptomatic. This anatomy is just so beautiful, but also so eloquent. So you have to be very careful that you select the patient that has already disrupted those fibers to allow it. And then remember that going lateral is perfectly safe. So here's a midline one. Patient already had all sorts of problems. And so it came right to the surface. It was easy to take out, and you have this cavity left. But the patient did have residual symptoms. More interesting to us is really the ones that are off the midline, where the foramen of Luschke is a pathway, where you're going through the medial cerebellar peduncle. And so here the feet are up here, head is up here, little gel foam into the fourth ventricle to prevent blood from going down. And then all we're going to do is go out the foramen of Luschke. Pica sitting there, opening the tila choroidea. And then the white fibers of the middle cerebellar peduncle. And then with image guidance, we decide where we're going to enter. And then through a small opening. I mean, it's just fascinating that here it's so safe, so well tolerated, and you just go a centimeter over to the floor of the fourth ventricle, and you just can't do this. And so we end up removing it piecemeal. Here's the post-op. Retrosigmoid. Vladimir again already showed a nice case of that. Here's a patient with multiple cavernous malformation. And here you see the cavernous malformation. Left hearing is still present. She presented with left facial weakness and some motor symptoms. The key to here for me is that you want your surgical corridor to go right down the middle of the cavernous malformation, not here where it's easiest to get to, but here because you want to be equidistant from both sides so you can bring the cavernous malformation into the cavity that you have created. And with image guidance, it's so beautiful because you know then you're at the end. And here it is. We're coming down farther and farther along the fifth and the 7 and 8 cranial nerves to get to the brainstem to get that angle that we were just talking about. And here it is along the 5th cranial nerve here in the brainstem. We make that opening right in that corridor that I said. A lot of recent hemorrhage, so it's easy to remove clot and give us more and more room. And I as you're taking it out, I always keep thinking must be growing in front of my eyes because you just keep taking out these big pieces of cavernous malformation. But it really comes out very nicely. And there's the post-op, you can see. And as, again, Vladimir mentioned, here the left hearing was preserved, just remarkable. I point this one out because here's a recent hemorrhage with a cavernous malformation, only to emphasize the cerebellar peduncle, the petrosal fissure, and getting utilizing the fissure to get access. Here's the petrosal vein. Always leave it intact so you don't over retract. Notice no rigid retraction is in place. It's all just with the instrument. And then we're going to open the petrosal fissure between the cerebellar lobes. It's a little more fragile than the Sylvian fissure, but you can open it very nicely. That gets you again down to the middle cerebellar peduncle, which is so robust and allows you to transgress it without neurological sequelae. And then we just march up that petrosal fissure. And then you see the white fibers of the white tracks. And then once with image guidance, we get the right angle, we can then go in and get to the lesion. And this is incredibly well tolerated. And just spreading the fibers and getting there to the lesion. And here it is out. Supracerebellar interferential, I love that approach. It is something that's beautiful because it gives us access from so many different angles. This tentorium between the cerebellum and the temporal lobe and occipital lobe just gives you such a great avenue for these lesions. And you have different positions that you can utilize. Again, no retractor in place, coming down to the ambient cistern through a small opening and going right. This is a very lateral approach. You saw the fourth cranial nerve. We get right to the cavernous malformation and remove it in a straightforward pattern. And that comes out very nicely. And here it is. This, you could see where the entry point is. And this patient ended up doing very well. What is enough? What is enough? How far can you go with this approach? This is a patient that previously been operated on elsewhere through a subtemporal approach, came from Wisconsin. He had a big rebleed, and we decided to use the same approach. Now we're going to cut the tentorium because we need to go superior. We need to go farther up. We remember that the fourth nerve is subarachnoid, so it's perfectly safe to cut the tentorium as long as you're staying extra-arachnoid, pushing it back. And then with image guidance, we make a decision of where to enter the midbrain. We get to the cavernous malformation, and we take it out piecemeal, and we keep going, and we keep going until it's all out. Notice again, no retractor. We're just using that avenue and using what I call the dynamic retraction. And that's what it looks like post-op. His lesion is gone. He's the same. And then his referring neurosurgeon lets me know 4.5 months later that he is able to ambulate independently. He came in a wheelchair with much better balance. So a very gratifying case. This is the last one from this approach that I want to emphasize how far we can really go. Patient had been operated on previously with a shunt from Europe. Here's the cavernous malformation. I mean, extending this big. You can see it goes all the way up to the foramen of Monroe. And again, I decided on a very far lateral supracerebellar infratentorial approach. Cut the tentorium because this time you're going to have to go way up, all the way up to the foramen of Monroe. Through a small opening, we get to the cavernous malformation. We just keep taking it out. And at times I had to use a little laser to make the pieces smaller enough so that I could get them out because they were just too big and I couldn't cut it with the scissors. And we get it out, and we get it out, and we keep going. And just keep taking it out. And here, at the end of the procedure, we're all the way up. Contralateral foramen of Monroe. And here's the post-op. And here she is on her way back. So you can really go very far. And we're up to the OC approach. It's a patient at 3 episode, very young woman. She had this cavernous malformation. And the question is, how do you get there? And I think we can all agree that ipsilateral, you're not going to get there. So we're going to go contralateral OC approach into the interpeduncular space to get to this cav-mal. So here we are on the opposite side, internal carotid artery, optic nerve. Turns out that going between the optic nerve and internal carotid artery is the best angle from our approach. So now we're looking into the interpeduncular space with all the tiny little vessels, and then we move them aside depending on, now we're looking at the peduncle, depending on image guidance. So I double, triple check the accuracy of image guidance. And then we open and relieved when I encounter the cavernous malformation. And then we remove the lesion just like we do with everything else. These are teeny tiny little pituitary-like instrument that I had made to get it out. And there you can see the angle that we came in on, and she did very well. Finally, transcallosal. I already showed you the one with a medical student. And here we have a cavernous malformation in the third ventricle. Again, I like the patient horizontal, the bone flap across so we can pull the dura over and get just a few more millimeters here. And then we go down to the corpus callosum, open it, open the corpus callosum. We see the foramen of Monroe, the choroid plexus. I like to go lateral to the choroid plexus to further provide protection for the fornix. The fornix is a critical structure, and we have to be incredibly aware of its significance. So by going lateral rather than medial, as described in most textbook, you have one more layer of protection for the fornix. And here again, I'm using the little laser to separate the cavernous malformation from the roof of the third ventricle. And it really comes out very nicely. And again, you see no retractor in place. And there's the post-op, and it's gone. A little more difficult now is this one. Young man from Israel, he has this cavernous malformation which extends into the aqueduct, the posterior portion of the third ventricle. You can see the lesion as it extends third ventricle and into the aqueduct. So here we have to get all the way here. So we're going to use exactly the same approach that we did on the other one. And now we're in the third ventricle. And here I need a retractor to hold over the corpus callosum. So I'm never saying don't use retractors, just don't use it if you don't need it. And here we're looking right into the opening into the aqueduct. So again, very carefully, we're moving the lesion in a piecemeal fashion. Again, you have the lighted sucker, which is a very nice tool when you're down in a very deep hole. And we just keep taking it out. And there comes the last bit. And here it was, before, after. Before, after. And then finally, the last case I want to show you is that they come in all sizes. What is also important is that this is a cavernous malformation within the sinus. And these are totally different than when they're in the brain. They are very vascular. And when they occur, like in the cavernous sinus or elsewhere, they are very amenable. And I know you're not going to believe me when I say this, but they are very amenable to radiation, whether it's CyberKnife or Gamma Knife, because they are so much more like an arteriovenous malformation. So this is a patient that was operated in their home country, and they had surgery for 16 hours, didn't know what it was, had severe blood loss. Then it was in Houston. They also tried it. They also had to stop because of the blood loss, because they didn't recognize the nature of this disease. These are very, very vascular. This is the lesion itself. You can see it's within the lateral sinus itself. You see the split of the sinus. And here the sinus is obstructed by the lesion. And Dr. Albuquerque, my colleague, found this one little external feeder. And you could have bought 3 Mercedes-Benz for the amount of onyx that he deposited within the lesion. First thing I did was make the craniotomy bigger. Then all I did was go to each side of where the sinus was, cut the tentorium in the sinus, and suddenly you had a lesion that was nothing more than a tumor. You could see the sparking from the onyx that's been deposited within the lesion. But actually, I mean, there's nothing to taking it out once it was devascularized. And I probably didn't need the embolization because I was able to get to the 2 edges. So here's one end of the sinus, and then the other end is on the other side. This is him. That's his beautiful mother. I was disappointed she kissed him instead of me. I did all the work. And there it is. So everything that we're really talking about is what we have learned from all these lesions is, why isn't that going? Anyway, we've learned a lot from these lesions, and we put together what we call the safe entry zones. And everywhere where you see those little green marks, we were able to enter and have minimal or acceptable neurologic deficit. So all these cases are in these books, along with the videos for anybody that wants to review them. So in conclusion, I think surgical resection of symptomatic and accessible brainstem cavernous malformations and spinal cord cavernous malformations is reasonable. Anatomy, anatomy, anatomy. Appropriate exposure really lets us get to any portion within the CNS. Selecting the right patient is the key. Anatomy, anatomy, anatomy. I thank you all for your attention. And Imad, I thank you very kindly for your generous invitation.
Thank you very much, Bob, for this wonderful presentation. I think you made it all. You made what Michelangelo did, the genesis of modern contemporary vascular neurosurgery. Thanks for sharing your experience with us, an unbelievable experience. I'm just wondering why they say Bob Spetzler retired and sitting home watching his video. He should be in the OR.
To tell you the truth, Imad, I'm in Wyoming, in the mountains, and I am just waiting to go skiing.
Yeah, life is, God bless you, is short, and we have to enjoy our life as well. Okay, any comment or questions?
Can I have one comment, please?
Yes.
Yeah, but always a pleasure and privilege to listen to Dr. Spetzler. You know, when there is a small cavernous malformation inside the spinal cord or in the brainstem, which has bled in the past, maybe multiple times, we get sometimes very late and we decide to operate. Until we reach the real cavernous malformation, I mean, my heart rate is 150, 180. And because that every millimeter we go in, we just worried that we may go astray and then create a problem. I have found a little bit of use of this very fine ultrasound probe sometimes in these locations. What's your comment? Have you had, because in spite of all the image guidance, that sub-millimeter accuracy is not there in the brainstem when there is some CSF shift, and unless you have an intra-op MRI, which we don't have, I think the new generation ultrasound has helped us in reducing my heart rate. Yeah.
Well, Basant, anything that reduces your heart rate, I think, has to be encouraged. I also want to say hello to all my friends that I see that are present. It's always a pleasure to see everyone and recognize the incredible camaraderie that exists worldwide among neurosurgeons. Basant, I do not have any experience with a very small ultrasound. I've really depended very much on image guidance alone.
I have one question of chiasmal cavernoma. I've confronted 2 times with the cavernoma in the chiasm leading to partial visual loss. I tackled one of them that has blood, did well, stabilized, but did not improve. The other one did not do very well. Have you seen these cases in the optic nerves or chiasm?
Yeah, I think we actually published a number of chiasmal cavernous malformation. I think the chiasm is about as eloquent an area as there is, in the sense of you do not have a lot of maneuverability, retraction, being able to take too much of the yellow surrounding area. I think you have to be very judicious. But I think we've had like a half a dozen of chiasmal and optic tract cavernous malformations.
Okay. Any other comment or questions?
Yeah, I would like to ask, some of those spinal cord cavernomas are not compact, like easy to resect. Some of them are like disrupted. How far would you go?
Yeah.
Chasing all those blackish tissue or not?
Yeah, you are absolutely right. In fact, I have pictures of, like, in the posterior fossa on the floor of the 4th ventricle, where you literally have hundreds of tiny little lesions that are not coalesced. They are not part of the one single structure. In the spinal cord, that is more frequent. And what I do is if there's a lesion that has bled and I'm operating, I pick at everything that I see, but I know there are others that I don't see.
Yep.
Any other questions? It seems you covered it all. Now we have selected one of your previous people who became a leading figure in neurosurgery. He is part of the Barrow sport team, I recall, in your Mannschaft. Jack Marcos will be the next presenter.
Yeah.
He will talk about a very interesting title, the role of bypass for management. Bringing the science of flow to the craft of bypass surgery. Gratitude of us.
Thanks a lot, Imad. Robert, always good to be with you. For some reason, can we unshare your screen, Robert? I can't seem to get through. Let me try again. You're muted, Robert. Huh. I don't know why it's not letting me share. Can you hear me, Imad?
Yes.
I'm not sure what's going on.
Robert, you have to unmute yourself.
Yeah,
now we hear you.
Yeah, but I can share screen, but I can't unshare.
No,
the
I have
host
done
has
it.
to.
I have done that already, Professor Claire, so I've unshared you.
Oh,
Okay.
you've unshared
Try
me?
again, Jack.
Yeah, I'm trying. For some reason, doesn't select my PowerPoint. I don't know. Let's see. You know, Imad, you want to go to the next speaker? I'll try to figure out what's going on.
Yeah, I will give the chairmanship for Professor Ramesh Nair, who's chairing will be the
I don't
session.
want to delay you.
Vasanji, you talking, you're muted. We can't hear you. You saying something about
Jack, it happened to me the first time. You close it and come back, it will work.
Close what? The Zoom or the PowerPoint?
Then just the PowerPoint and open it again.
Really?
And then come back. Yeah, this happened to me. My talk wouldn't come, but the second time it came.
Okay, let me try it again. Give me a few seconds.
Well, with your apologies, I'm going to go skiing.
Good luck. Thank you.
And be careful. Take care. Hope to see you sometimes in the future. Take care.
You all have a great meeting.
Thank
Bye.
you. Bye-bye. Enjoy.
Downhill or cross country?
Jack, are you able to unclose your PowerPoint and?
I did it and reopened it, and it's
No,
doesn't.
no. You started sharing. I don't know whether you pressed that green button to share it or have you not.
When I click share, usually it gives you a window to select things from, and they're all.
Yes.
They have an exclamation mark on them as if
Yes.
they're not open for some reason.
Ramesh, should we go for the next presenter by that
Yeah,
time?
is that okay, Jack? We'll go to the next. Yeah, so it's my pleasure to call Prof. Giovanni Brogi, who's going to speak about the role of bypass in complex aneurysm. Giovanni.
Okay, I try to share the screen.
Yes.
Wait. I have the same problem of Jack. Let's see.
You're having the same problem?
Yeah, I think so, because now I try to share the screen. Okay.
Yeah.
You see me?
Yeah.
Yes, you are there.
Okay, now let's move these stupid things. Okay. So, season greetings to everybody.
You want to try the slideshow, Giovanni?
To be, sorry?
Are you on the slide mode, the presentation mode, or you?
No,
He's already.
You hear me?
We hear you, yes.
We can hear you, but I don't know whether it's in the presentation mode. It's just the.
You see this? You see the screen?
Yeah, we can see the screen.
Yes.
Okay. So, first of all, thank you for the invitation, and I will be very, very fast. I would like to give some contribution to this bypass approach for the management of intracranial and complex intracranial aneurysm, the giant aneurysm. But everything is already said by the previous speakers, mainly by Bing Sung about the type of the bypass and other things. So my presentation will be very, very fast. First of all, thanks Robert Spencer for what he did for all of us. I'm very happy that he's going skiing, and that is the history of the treatment of giant aneurysm from the early 90s to today. Before this, there was the Yosobuchi was making wires into the aneurysm, and after Guglielmi came out, and later on, at least in Europe and mainly in Italy, in 2011, the flow diverters came, and we already had the discussion about what is the advantage and disadvantage of the flow diverter. So you see here some publication, and what we can really see is that in this study that was tried, that was done in Europe, the flow diverter are not so let's say they give not the possibility to treat every kind of aneurysm, and Again, that time there was the flow diverter used was off-label for the complex aneurysm, but that is not what is today. So I would like to share our experience, the single center. That is something that is not about the complexity that when you get together all the results of many centers. This is our experience. A few number of patients, 23 patients from 15 to today or to last year. And you see here is on the MCA to the anterior carotid aneurysm, to the carotid aneurysm itself. This is the characteristic of the aneurysm. This is the Cavernous pre-op, and this is the post-op. As you see, of course, that is something has to be paid for this treatment. But I think that surgery still has an important, and that is the reason why we presented this, is a very important advantage toward the treatment of this patient. This is the list of the different aneurysms, but to be very simple, you see here the 11 was the patient, and with that is the type of the bypass that we did, and what we did after the bypass, that is clipping or trapping of the patient of the aneurysm. And in one case, we did the intracranial bypass with using the STA or simple or double branch, as Professor Bingsung will show us. This is the example. You see here the type of the aneurysm as it is, and this is the reconstruction. Let's go ahead. It's not working. And to be very short, to show this video, of course, this is the preparation of STA, and there is nothing new. The only things that is important is to that was already showed many times, so I go very fast. The preparation of the receiving vessel, that is something that I think is very important. It was already mentioned too, and all the lecture of Bingsung was about the property of the donor of the vessel, recipient vessel. I think that is very important to know what you are working with. That's the usual way to do the bypass. I'm not going inside. We're using, I personally used the separate stitches and not the continuous stitches, but that has to be discussed at that. And this is the other very important thing, is the step of with the ICG that told to the team what is going on, and also the user 800 of this fluid-tandem analysis give you all the images and what the properties of the revascularization. And of course, afterward, you can do the proximal occlusion and the distal occlusion and to reshape the aneurysm. And of course, every step has to be done with the control of the video angiography. And that is the end. We did also, in this case, also the fluorescence just to see if the perforants are intact or not. And that is another trick that can be added to the to the procedure. Okay. And this is the post-op. And you can see that everything's run well without any problem to the surrounding tissue. Let's go to the ICA aneurysm. 6 aneurysm. This is the characteristic sacral, fusiform or not. And this is the simple STA-MCA, the bypass, or you can be used also in some other cases, the double barrel. And in 2 cases, the radiograft. That is, I think, this is something that has to be taken in consideration in preparing, and of course, being able to change the strategy if the pressure in the STA is not enough to provide a good revascularization or good recirculation and perfusion to the brain. This is one case where a very young boy, young male, with no neurological deficit. You see here the characteristic of the aneurysm, and let's see if going very fast. This is the angiography. And that is the usual things, the actual performance of the bypass. This case was done by Francesca Cervi, and that is the bypass preparation, the suture of the bypass. And we do use also some to protect the suture, some piece of muscle that is a kind of hemostatic help. And of course, afterward, you can treat the aneurysm with a different type of clipping control at the end. And this is the post-op on the case. And this is the angiography. That was very important, that the sac of the aneurysm was not completely closed because of the perforators. And that we did a kind of reperfusion of the perforator through the remnant of the sacral that is completely soft in this case. But as you can see here, 6 months later, all the aneurysms collapsed and went away. So that is something that you have to control during the procedure. What about the ACOM? This is a total 6 cases. We did the pericallosal bypass or double intracranial bypass in one case, and you see here the subsequent grafting of the aneurysm and the way to do the reason to do the bypass in between the pericallosal arteries. This is the schemas of procedure. This was the bypass performed, and that is the other trapping. And going very fast, here all the story of this aneurysm. We use sometimes also the intraoperative ultrasound. That was the question raised to the Bob Spencer about the Cavernous malformation, but I think it can be used also as an help or more, sometimes more than the monitoring, use of image-guided surgery. That is the performance of the bypass between the two arteries, the two pericallosal. Let's go fast because of the time. And I don't want to annoy you. We saw so many video performing this kind of bypass, and I think that is something that young people has to learn immediately in their training. I think it is very, very important because the technique seems very simple, but it's not so simple, and the use and the training is quite important. So that is the end. Was the bypass that you can see here in the post-op control, and that is the pre-op, and this is the post-op, and you see here it's gone, and the coil were put later on. This is post-op and control. And the last question is, what about the posterior circulation aneurysm? Professor Cato told us this morning some example of this approach, but I think that remain a question mark. And I think that also in this situation, bypass may have a lot of treatment of this aneurysm, more than in a case in which the flow diverter cannot complete control the pathology. This is something that you can find in the literature. The conclusion is that again in this article, that surgery has still a place, and that is the question: what do you do in this case? That was called all the aneurysm, but that's the malformation is still away, and that is, I don't know what we can propose for these particular cases. If go again on surgery, with the surgery, what type of bypass we can do. So at the end, I thank you for your attention, and I hope that I not only stay in time, but we gain some time for the discussion. Thank you.
Thank you. Thank you, Prof. Broshid. That was quite exhaustive and comprehensive view of the complex bypasses for certain complex aneurysm. I would like to hear some comment from some of the speakers here. I think Prof. Binsu, not sure whether you're still there. And Prof. Binsu, you want to comment on the talk or any?
A great talk, Professor Roach. And now, because of the popularized use of the flow diverter, now the bypass cases was decreased a lot. Before we use flow diverter every year, I will have around 30 cases of bypass for aneurysms. But now it's only left less than 10 cases for the complex aneurysms. Because I'm the hybrid neurosurgeon, so I'm both doing the open surgery and the flow diverters. Sometimes actually the flow diverter is very useful, and you have a question that is it a low risk method to treat the complex aneurysm? I think my answer is yes. So it's very helpful.
Okay, thank you.
But we still have some in the very complex aneurysm, especially at the location of M1, M2 segment. So this kind of segment, the flow diverter may be cause maybe cause the small peripherals delayed occlusion if you use fluid diverter. But so at this segment, we still use bypass. Normally use radial artery as a graft.
Yeah. Okay, thank you for your comments. I think the big problem about I think that surgery is not against you have to use in a single cases and what is the best of the patient. And I think the team decision is very, very important. And I think that all the webinar today show that how the advantage of the surgery toward what is properly safe, not invasive, because that's, at least in my country, flow diverter are considered not invasive. And that's the big problem. Thank you.
Thank you.
Thank you.
Yeah, any other comments? I'm not sure Prof. Soichi is still around, because after 1 o'clock in Japan, if you want to comment on this. But if not, if no other comments or questions, I'll ask Prof. Eckhard Kasper to take over the meeting. Ek, are you there? Unfortunately, Prof. Jack Mokos could not present his talk, but because he wasn't able to start the presentation, but we'll probably bring him back for another meeting, one of our meetings. Ek, are you there? If not, then I will go on to the next speaker, who's well known to us, as part of us, Prof. Baldacchini, talking on aneurysms. Matthias, all yours. Thank you.
Hello, everybody. I hope you can hear me okay.
Yeah.
Thank you very much, Imad, Vladimir, and all the faculties and speakers in this special webinar honoring Professor Robert Spetzler. The topic that I will talk, it's about an uncommon aneurysm location in the A1 segment. The title is Microsurgical Clipping of Aneurysms Located of the Proximal A1 segment. It's a huge honor to me being a young neurosurgeon from Argentina and to be part of this webinar honoring Professor Robert Spetzler, who inspired me and so many young neurosurgeons around the world. And I had the privilege to work in 2 research papers, and we have published 2 papers with Professor Robert Spetzler. The A1 segment, this is important to remember the anatomy. First of all, when we need to prepare a case, we need to study a case. If it is a tumor case or vascular case, it's important to remember the anatomy and to study the particular anatomy of our surgical cases. Here we can observe this beautiful anatomical specimen where here is located the internal carotid artery, the middle cerebral artery, and this is the A1 segment. The A1 segment originates in the carotid bifurcation and ends at the level of where the anterior communicated artery joined both anterior cerebral arteries. And this segment is separated. This is the A1 segment, and it's separated in 3 different segments. This segment is the proximal segment, the intermediate segment, and the distal segment that is really close to the anterior communicating artery. And from a microsurgical point of view, when we need to operate aneurysms located in the A1 segment, we will use, or we can use 3 different corridors. The lateral corridor located between the lateral border of the carotid artery and the lateral border of the middle cerebral artery. the medial corridor located that it's formed by the angle between the medial border of the internal carotid artery and the inferior border of the A1 segment, and finally the angle between the bifurcation of the carotid artery between the middle cerebral artery and the anterior cerebral artery in the A1 segment. These three corridors we can use for dissect this kind of rare aneurysm or to clip this kind of aneurysm. This is a microsurgical view. It's similar, and this message is especially for the young neurosurgeon. We need to pass from the laboratory, the image that we have dissected in the laboratory to our microsurgical dissection. This is the internal carotid artery, the middle cerebral artery, this is the A1 segment, the proximal, medial, and distal A1 segment. And it's important to remember that from the posterior border of the proximal segment of the A1 artery, we will find small vessels that are the medial lenticulo-striate arteries. In green, it's highlighted the medial proximal, the proximal A1 segment, intermediate, and distal in blue, the distal segment of the A1 segment of the anterior cerebral artery. If we are dissecting through the space of the carotid bifurcation, we can observe here all these important vessels that are the lenticulo-striate arteries, and here we can observe an aneurysm located in the medial portion, the proximal portion, of the A1 segment of the artery. As I told you previously, the aneurysm located in the A1 segment could be located in 92% of cases in the proximal segment, but could be located in the intermediate and distal segment too. And the 93.8% of aneurysms located in the proximal segment projects posteriorly and inferiorly in this artery, and it turns this kind of pathology really difficult to dissect, because sometimes the anterior, the A1 segment is in front of our aneurysm, and it turns really difficult to dissect in our microsurgical windows. Here we can observe a small aneurysm located in the posterior surface of the proximal A1 segment. It's a small aneurysm, like a blister-like, and we worked for dissect and for clip this aneurysm in the medial triangle. We can observe here the video. This is a standard dissection. We open the Sylvian fissure. It's very important to open the Sylvian fissure in order to gain access to observe the carotid bifurcation, the origin of the anterior cerebral artery, as we can observe here. Here is the internal carotid artery, the optic nerve. This was performed through a right standard pterional approach. This is the proximal part of the A1 aneurysm, the A1 artery, and the aneurysm is impossible to observe in a direct vision, because it's located posteriorly to the proximal segment of this right A1. Turning the angle of the microscope, we can observe the aneurysm. Here is the aneurysm located. We can observe the fundus of this blister aneurysm, and it's really difficult to clip because we can't mobilize the A1 segment, because if we mobilize the A1 segment, we can generate some kind of vasospasms or lesions of the lenticulo-striate arteries. Here you can observe the aneurysm. This is why we decided to enter with our clip. We use a microclip, curvilinear microclip, between the angle between the carotid artery and the A1 segment. Here is the microdoppler. We check with microdoppler the dissection of the neck of the aneurysm with this special Penfield dissector, separating the neck of the aneurysm of these small lenticulo-striate arteries. This is why we use this mini clip, this curvilinear 5 millimeters mini clip in order to put the blades of the clips in surrounding the neck of these complex aneurysms. We use, in this case, the angle between the medial border of the carotid artery and the inferior border of the anterior cerebral artery in the proximal segment of the A1. Here, the aneurysm is clipped and the problem is solved. This was a really challenging case and was really, really difficult. This is another case. This patient is a young woman that she was operated some years ago for a contralateral gigant carotid ophthalmic aneurysm, and the patient was diagnosed with this small aneurysm located in the proximal segment of the A1. Here we can observe this is the regular pterional craniotomy in the right side. This is the internal carotid artery, and here we can observe the internal carotid artery, the carotid bifurcation, and the aneurysm growing in the proximal segment of the A1. And it's important to remember that in this part of the A1 segment, we will be finding this small vessel that in this case we found a lot of vessels, and these vessels are the lenticulostriate artery. It's very important to separate the neck of the aneurysm, the proximal and distal neck of the aneurysm, previous to put our clip for this kind of aneurysm. Here we are separating the vessels surrounding the aneurysms, and we selected an angle clip and 45 degrees angle clip in order to close the circulation to this aneurysm. Here is another case. This is a different case. It's a young patient with a subarachnoid hemorrhage, fissure 2, with an aneurysm growing through the proximal A1 segment, exactly to the previous one, but with the irregular shape in the angiography. We decided to operate this patient. Here is this is the clip after the surgery. This is the post-operative angiogram, and exactly the same. We expose the sylvian fissure. It's very, very important to dissect completely from distal to proximal the sylvian fissure. This is the internal carotid artery, the carotid bifurcation, the middle cerebral artery, and this is a different case. We have this yellowish color in the sylvian fissure because of due to the bleeding, to the previous bleeding. And here we can observe the aneurysm. The aneurysm was dissected, and in this case, for a proper clip of the aneurysm, we select the angle between the internal carotid artery and the lateral border of the medial cerebral artery in order to put the clips parallel to the neck of the aneurysm. Here is the middle cerebral artery, the anterior cerebral artery, and using this lateral angle clip, this kind of clip are really useful for ophthalmic carotid artery aneurysms, but it was very useful to clip these special aneurysm located in the proximal A1 segment in this patient. The patient was really well. This is another case. This is the last case that I want to show you. A young patient with a giant AVM located in the left frontal lobe with three different aneurysms: a posterior communicating aneurysm, and 20 millimeters a proximal A1 segment aneurysm, and anterior communicating aneurysm. We operate this patient. We treated only the three aneurysms in only one surgery, and we decided to not operate the AVM due to its eloquence in the left hemisphere. And we use for clip this aneurysm the lateral triangle between the internal carotid artery and the middle cerebral artery. This is the surgical video. We can observe here a left pterional approach We are dissecting here the carotid cistern. This allows to relax the brain. We are opening the medial portion of the sylvian fissure. We can observe here the posterior communicating aneurysm and posterior communicating artery. This is the internal carotid artery. This is the A1 segment, the proximal A1 segment, and the aneurysm growing and projecting posteriorly and inferiorly to the proximal segment of the A1 artery. Here we are dissecting with this special dissector, and after to dissect properly the neck of the aneurysm, we decided to put this 15 curvilinear definitive clip through the neck of this aneurysm. This was the first aneurysm that we clipped in this multiple aneurysm in this patient. I want to thank you again for inviting me, and of course it's an important day for us as Argentinian, because our country is a huge party. We have nowadays millions of Argentinian enjoying the World Cup victory. Thank you very much, Vladimir and Ayman, for inviting me and to share this topic.
Thank you, Matthias, and congratulations for this brilliant talk, and also congratulations for the World Cup. You deserve it. And I probably, I was trying to look for you, but is there any comment on any of the parts of the talk? Anyone? I just want to ask Matthias, it's good technique you have demonstrated for this relatively rare A1 segment aneurysms, and you use this side angle or lateral angle clip, which I think is quite useful. But do you think adding sort of endoscope to one corner below the A1 could give you some more vision, especially the first case you showed, which is totally sort of, because you have experience and you can clip it without any problem, but be useful to see the tip of the blades by an endoscope?
We didn't use an endoscope in this case, but I agree with you that if we have an endoscope, I think that this case is more easy to clip. And another microsurgical tool that I think that is useful, but unfortunately I didn't use for this case, is an angle micro mirror, a small angle micro mirror, in order to observe if the clip is well is collocated in the well position. It was this case was really a challenge, at least for me. In a moment of the surgery, I thought I can put a transient clip distally to A1 and I can rotate the A1 segment in order to expose the aneurysm, but I wasn't really sure that this maneuver can produce some kind of damage of the lenticular straight arteries. Yeah. But it was really difficult. But of course, the endoscope, I think that is really useful, especially a 30 degrees endoscope, in order to observe the neck of the aneurysm. Yeah. Yes.
Okay. Igor.
Yeah. Thank you, Ramesh. Thanks, Matthias, for this so beautiful lecture and brilliant dissections I saw in the beginning, and congratulations again for the World Cup. I heard in the radio today that it's holiday in Buenos Aires today, right? So everybody can make the party. So I have a question about the approach and the dissection of the sylvian fissure, because you showed some very proximal aneurysms, such as the first one, and you prefer to do sylvian fissure dissection from lateral to medial, and why that?
We in all in most of our cases, we prefer to dissect the sylvian fissure from distal to medial. In some cases, we select to dissect in a different direction, especially for those patients with subarachnoid hemorrhage. We prefer to start dissecting the carotid cistern and then trying to dissect from proximal to distal. This is at least our microsurgical school. And I think that it's more comfortable to dissect the sylvian fissure starting from the pars triangularis in the anterior sylvian point from distal to medial.
Okay, thank you. Eka or Vladimir, you can start and then I.
Yeah. Matthias, congratulations to the World Cup, of course. These aneurysms are difficult since they are hidden behind the vessel. You are doing your job on the opposite side of the vessel. And lenticular straight perforators are very, very able. So it means that you have to check and recheck each individual perforator, and then there is another one, then there may be another one. And this always seemed to me difficult because I do not see that even with an endoscope. It helps, but it doesn't show you everything. Mirror is a good one. Even from both sides, you cannot be sure that you didn't occlude one. Do you have some trick for this?
For the first case, I think that a fenestrate, if I hadn't many clips for this surgery, but I think that if we have a another surgical case similar to this one, I will select a fenestrated and short right clip in order to put two or 3 millimeters straight and fenestrated clip, one in the side of the other in order to close the base of the aneurysm. But I think that this kind of location are really a challenge because you have the anterior cerebral artery and that it's difficult to mobilize this segment, and of course you know that the lenticular straight artery can be injured during the surgery or can suffer vasospasm if you manipulate it a lot. It's really difficult. If you have a long lenticular straight artery, maybe you can put an transient clip in order to rotate the aneurysm, the A1 segment, and expose the complete base of the aneurysm. But in this case, the lenticular straight arteries were really short, and this maneuver could be really dangerous, I think.
Yeah, Imad?
Yeah, I think the idea of rotation of the A1 is in general not a good idea, because you will twist and angulate some of these perforators and this will never recover. It's not a matter of they recover immediately. They will go into spasm and it cause a lot of trouble. But I still believe the mirror and the endoscope, these are the solution, and the floor, of course, the fluorescein to make sure that you have clipped the aneurysm, you didn't leave a daughter aneurysm on ear of the aneurysm behind.
Okay,
yeah, Matthias, do you have any experience with supraorbital lead approach for this proximal one? Because our great approach for.
Yes, our team have experience using supraorbital approach, but not for this kind of aneurysm. We use the supraorbital approach for superior projected carotid bifurcation aneurysm. I think that is a straight route to clip this aneurysm. For anterior inferior projected anterior communicating aneurysm, or a posterior communicating artery that projects laterally without a fetal posterior communicating artery. Only for these aneurysms we have used the supraorbital approach, but not for these ones. I think that using a supraorbital approach could be difficult to see this posterior located aneurysm too. I don't know.
Thank you.
I believe that unlike in middle cerebral, when you can do as many maneuvers as you like, but still you try to limit them. In these aneurysms, you should limit your maneuvers to as few as possible, not adjusting the clip, just leaving it. Exactly as Imad has said, perforators go so willingly into spasms and they never recover. So one first putting the clip is usually the best.
Yes, another these are really uncommon aneurysm, but another beautiful route is using a pretemporal corridor in order to observe the aneurysm behind of the carotid artery. But it depends the rotation of the head with your head holder, the particular anatomy of each singular patient. It's complex. As you know, in the surgery, you can observe a lot of things that you can be able to imagine with the preoperative studies sometimes.
All right. Okay.
One more comment. Do you think a use of temporary clip will make this ingoit vessel slimmer for you to evaluate the dome of the aneurysm?
Yes, maybe, especially for the last case, that it was a huge base of this A1 aneurysm, but our team tried to avoid the use of transient clips in order to avoid the endothelial damage that it can produce. The use of transient clips. If it is necessary, if it is extremely necessary, we use it. But if not, we prefer to not use the transient clip.
Thank you.
We are finishing a study with rats where we use the carotid transient clip during 1 minute, 2 minutes, 5 minutes, and 10 minutes. And after 2 minutes, we are observing. Of course, we need to imagine this what happened in the human brain, but in the carotid rat, after the 2 minutes, we observe damage between the unions of the endothelium and the basal lamina after 2 minutes of transient clip of the carotid arteries in Wistar rats. We are trying to publish if we have luck in the future, but we think that if we can avoid it, it is better.
Okay. Anything else? I think in that case, Imad or Vladimir could conclude.
Yeah, I think from my side, I'd like to wish all of you a Merry Christmas and a Happy New Year. Hopefully next year will be a better one for the IANA. We concluded 5 courses, I think, very successfully, and the last one was, I think, after Nairobi. Did you go somewhere, Vladimir, or that was the last one for this year?
That was the last.
And we have 5 webinars. They were all successful, and I hope we will keep the momentum. I'd like to see some of the people, they are not contributing much, and unfortunately, of course, they are privileged to spread themselves thin for other societies, but they are not coming frequently to our commitment as you guys has been doing all this period. So, but I will give an encouraging message from me and Vladimir to all of them to be alert and to be contribution, because there are many people, they want to join and be active. So we'll give a chance for other members to be added on this committee rather than to have somebody who has distended from themselves almost completely for the whole year, and they are not doing much for the academy. I just want, it's not a punishment, but this is logic. Some people, they are not very keen to be in this group because they have other options in their career development, and I understand it. But then we open the door for other people who are interested. If any suggestion come up, please take that venue, because we are among the family here in this session. Vladimir?
Yeah, well, I think that we have given today ourselves very nice Christmas gift. That is, this was